we're trying to make sure that those of our colleagues who are joining from YouTube can also hear us. So we just give us 1 minute to make sure that it's live. Is it live now? Can I get a thumbs up, team? Abimbola, can I get a response, please? Okay, welcome everyone. Thank you for joining. We are kicking off now. In the next 1 minute, we should be up. I see that the streaming has come up now. So those on YouTube can also join us. Wonderful. So welcome to everyone who is here with us on Zoom and those who are also on YouTube. Thank you for joining the session. We're truly happy to have you here today as we kick off the celebration of World Hypertension Day 2025. It's such an honor to be here today, and we are grateful to the Nigeria Hypertension Society for this opportunity as well. So we'll run very quickly through a lot of the housekeeping rules, and then we can start. This session will be recorded. So we will be putting on the recording now. The whole essence of recording is so that we would have some of the information and the lectures that we can share with you afterwards. So please feel free to put on your videos as we go through so that we can see your faces as part of the program. We'll also, I'm sure all of you who joined have filled out a form. And the whole essence of filling that out is so that we're able to, can you still hear? Can you still hear me?
Yes, we can hear you.
I hear you now.
Great. So we're going to be taking this polls, taking questions and answers. You're going to be given a poll, and all this is for us to be able to ensure this, as well as do the evaluation and continue to improve our processes. Okay, next slide, please. Just some key participation tips. Please, like I mentioned, feel free to leave your cameras on. The session is recorded. Please use the raise hand feature if you have any questions. We would also like people to introduce themselves in the chat. It would be nice to know where you're joining us from. Tell us where you're joining from. If you have colleagues with you, feel free to introduce them as well. Let's know how far and wide this has gone, right? How many people, where are you representing? Are you in Nigeria? Are you in Ghana? Are you in Kenya? Are you in Abuja? Are you in Sokoto? Are you in Lagos? Let us know. We also want to encourage you to use the chat function. If you have questions, comments, thoughts, if you're having any technical challenges, please use the chat function. The team is working behind the scenes to provide you support through that as well. This particular session is brought to you by a collaboration between the Nigerian Hypertension Society and MDoc Healthcare. Next slide, please. Hi, Akin Obemi, welcome. Chima, I see Chima from Lagos. Thank you for joining the session. I'll just give you a brief idea of who MDoc is. We are a digital health social enterprise, and what we do is optimize the end-to-end self-care support of people that are with regular health needs, e.g. pregnancy, and people with chronic health needs. So think hypertension, diabetes, obesity, cancer, anxiety, depression. We do this work through our four-pronged approach, which involves our online digital virtual-led platform called Complete Health. That's our proprietary platform that allows individuals track their health metrics. So I know I'm speaking to healthcare workers here. This Complete Health app serves as a complementary support. It serves as complementary approach to supporting your patients. So they are not our patients. We don't diagnose, we don't prescribe. What we do is support them to ensure that they adhere to the treatment regimens that you have provided for them. We also have our NaviHealth.ai, which is a platform that allows individuals find the services that they need when they need them. So for example, your hospitals can be on NaviHealth.ai so that individuals in your state, for example, who are looking for services can search for you and find you, use your services, and also give feedback on their experience within your service. We have our MDOC Quality Network, which is the platform on which we are doing this capacity building. What we do is train individuals to continue to improve the quality of care, both for healthcare workers and for the members that we serve, that's the patients that you treat. We have our Nudge Hubs, which allows everyone walk into a Nudge Hub, speak to a healthcare, a coach, and get referrals to a healthcare facility if they need one. Going to the next, please. So we have, like I mentioned, our Navi Health and our Complete Health platforms. To sign up, these are the links. We'll put the links in the chat as well for you to sign up to join. Okay, so the agenda for today, following my introductions and guidelines, we'll have a brief welcome address from the president of the Nigerian Hypertension Society. We'll have a couple of goodwill messages from our chairpersons, and then we'll launch our pre-quiz. We'll meet the speakers for today who are talking on very critical topics. And then we would also jump into some discussions. We would have our chairpersons facilitate a lot of this discussion because we want to leave here full of knowledge and reminded of some of the things that we've learned years ago. We also would do a post quiz because it's important to make sure that as we're learning, we are taking away things, critical things that would help in our practice. And then we will close the session. So I see a lot of introductions in the chat. Thank you so much, everyone, for joining. I see people from Lagos and other locations. Happy to have you here as well. So for the program executives for today, we have our chairperson, so our chair lady. Can you still hear me?
Yes.
Great. We have our chairpersons today. We have Professor. Okay, we have Professor Hadisa Saidu. I'm trying so hard not to murder anybody's name, but my elders, I ask for forgiveness in advance, in case. So we also have Dr. Olaoluwani. We have, of course, the president of the Nigeria Hypertension Society, Professor Simeon Isezua, and we have the secretary as well of the Nigeria Hypertension Society, Dr. Oladipupo Fason. So we would start off very quickly with a welcome address from the president of the Nigerian Hypertension Society, Professor Simeon Isezua. Please, over to you, sir.
Thank you very much, Adora from MDOC Healthcare Limited. Distinguished colleagues, ladies and gentlemen, it's my pleasure to welcome you to this seminar marking 2025 World Hypertension Day. As we are all aware, May 17th is dedicated to World Hypertension Day, and the objective is to raise awareness to ensure prevention, early detection, and control of hypertension. The theme of this year's World Hypertension Day is measure your blood pressure accurately, control it, and live longer. As colleagues, you will all agree with me that accurate blood pressure measurement is even more important in pregnancy, where we don't just use the conventional method in terms of determination of diastolic blood pressure, particularly. And as you will hear from experts, sometimes it is the change in the value of the blood pressure that matters rather than the absolute value. So this seminar titled Hypertensive Disorders in Pregnancy is quite timely and consistent with the theme of World Hypertension Day. I want to welcome all of you and request you to listen patiently and participate actively in this seminar. Thank you very much, and have a very fruitful deliberation. Thank you.
Thank you so much, sir. Sir, so I would give you the privilege as well, or the honor of introducing the chairpersons so that they can also give their goodwill messages.
It's my pleasure to invite Professor Hadiza Seidu, who is a cardiologist and a very senior person, highly committed and dedicated, and also a chief executive of one of the frontline hospitals in Kano, to kindly give her goodwill. Thank you.
Thank you, sir. Mr. President, the President of the Nigerian Hypertension Society, senior colleagues, our partners from NDOC Healthcare, and all other participants present, all protocols duly observed. I thank the Nigerian Hypertension Society for inviting me as one of the chairpersons for this very important webinar with the carefully chosen theme of hypertensive disorders of pregnancy. Hypertensive disorders of pregnancy are significant conditions that have impact on both mothers and fetus with significant morbidity and mortality. Early detection allows prompt management, reducing risks to mothers and the fetus. As the management is multidisciplinary, the Nigerian Hypertension Society has done a great job by inviting relevant stakeholders that will do justice to this very important topic. I therefore wish us to have a very successful and educative webinar. Thank you again for the opportunity given to me by the prestigious Nigerian Hypertension Society. Thank you.
Thank you, Professor Hadiza Seidu, for your goodwill message. May I also respectfully invite Dr. Oni, Professor of Obstetrics and Gynecology from my alma mater, College of Medicine, University of Ibadan, and University College Hospital Ibadan. You are welcome, sir. Hello.
Dr. you cannot mute.
Yeah, thank you so much. Thank you so much for inviting me. I'm actually happy to be here as the co-chairman of this webinar today. I appreciate the president, in person of Professor Simeon, for in actually selecting this very important topic for us to discuss in this webinar today. I also use standing on the existing protocol. I appreciate the speakers that have been well stated. Dr. Garba, who's an obstetrician, Dr. Loretta, pediatrician, Professor Adijumo, who is a nephrologist, and Dr. Ayatu, who is a consultant cardiologist. You are all welcome. I think this is actually a very important webinar, and I appreciate the society, Hypertensive Society, Nigerian Hypertensive Society, for actually selecting this very important topic, which is on hypertensive disorders of pregnancy, which is the theme of the World Hypertension Day for the 2025. Is a very thoughtful topic to consider, taking into consideration the huge burden of disorders, of these hypertensive disorders we have in our health facilities, and what has been the implications on the families, the patient, and the society at large. Hypertensive disorder of pregnancy is fast becoming the dominant cause of maternal mortality, as most of the speakers will be telling us, and is overtaking obstetric hemorrhage. And it's something that is actually necessary for us to look into. And thank you so much for inviting me, and I believe we'll have a lot to learn from this array of speakers that have been well selected from all specialties that are involved in managing this hypertensive disorder in pregnancy. Thank you so much.
Thank you very much, Prof. Boni, and over to you, Adora and Doc. Thank you.
Thank you so much, sir. And thank you so much, Mr. Chairman and Madam Chairlady. So we'll move to the next thing on the agenda. Again, this is a collaboration between the Nigerian Hypertension Society and MDoc Healthcare. And so every person that is here should be a member of the Nigerian Hypertension Society. If you are not a member and you would like to become a member, it's very simple and very easy to do so. We'll put the link in the chat for the Nigerian Hypertension Society. Just go on the website and you'll be able to click on the red icon that says membership, and you're well on your way to becoming a member of this prestigious society. So please go through the link and become a member today. Next slide, please. For CPD points, we will be awarding continuous professional development points for this particular session. This is for doctors who are practicing in Nigeria. If you are interested in having this, please feel free to send in your full name, your folio number, your qualifications to the email that is on the screen. We would also put it in the chat. The training, of course, is free, so you are not paying anything to be part of this training. However, the CPD processing would cost 3,500, and it is, again, for those who would like to get CPD points from this session. Only doctors who are practicing within Nigeria that are eligible for CPD points can request for them. We would also like to encourage participation in the session, as we will understand that providing CPD points, also we need to prove that you were part of this session for a substantial duration and you participated in the process as well. Okay, next slide, please. So we'll be launching our pre-quiz. I just need to give us some information. Don't worry about any, for the pre-quiz, what we're doing is trying to understand where we are now. How, what do you know now? What do you remember now? And then at the end of the session, we'll do a post-quiz. So don't worry, nobody's going to penalize you if you don't know the answers. Pick the answer that says to you, or pick the answer that you think is the most correct to any of the questions. There are just 8 questions. And then we would go through the didactic sessions with all the speakers, and you'll be able to get more information. So it's 8 questions. We will give 5 minutes for everyone to be able to take the quiz. So please go ahead. Speakers cannot take the quiz, chairpersons cannot take the quiz, and the NHS executive cannot take the quiz. So but every other person who, of course, the MDoc team that is behind the program cannot take the quiz either. So please feel free to take quiz. If it's not showing on your screen, please let us know. Please indicate in the chat so that we can support you. If you are using a handheld device and it's not popped up on your screen yet, just go down to where you have chats. You would see polls/quizzes, depending on the device you're using. If you click on that, it will launch it. If you're using a laptop or a desktop, at the bottom of your screen where you have participants, chats, if you click on more, you will see polls and quiz. Or it may already be showing the polls/quizzes. Click on it and it will pop up on your screen. For those on YouTube, we'll be putting a link in the chat for you to be able to take the quiz. So on YouTube, there'll be a link in the chat. Don't worry, it's the same questions. You'll be able to take the quiz as well. So we have 5 minutes for the quiz. And at the end of 5 minutes, we will close the polls. Please attempt the questions. It's part of the process as well. All 8 questions. Thank you. So I see that the quiz closed. I think there was a challenge somewhere. So please, can we relaunch the pre-quiz? Okay. And anyone who is a co-host, please do not touch anything on your screen. You may interrupt the quiz. Apologies to those who already started taking the quiz and it went off. Apologies. Please try again. Those on YouTube, a link has been posted. So if you're a co-host, please do not move. You're on freeze until we finish the quiz because you may interrupt the quiz. Okay, we're waiting for your answers to come in. Don't overthink them. I see some answers coming in. Don't overthink it. We're going to go through the sessions and then we'll do a post quiz. So don't overthink it. Whatever you think the most correct answer is, please feel free to pick that option. I see some people already answering. Please, co-hosts, do not move. You're on freeze so that you don't interrupt the quiz again. Thank you to all those who have completed the quiz. I see some people are already filling it in. Yes. So I would just add an additional 2 minutes because we had to restart it. If you're unable to see the quiz, please feel free to reach out to us. Thank you. We have a good number of people who have answered. We will be closing the polls shortly, so please hurry up, finish reading and selecting the best answer so far, and then we will come back to it again after we've gone through all the sessions with the speakers. Unfortunately, we will not be letting AI take note takers on this particular session. So please do not initiate an AI note taker. We are recording the session, and at the end of the session, we will send the resources to everyone who registered to be part of the session. Thank you so much. Thank you to everyone who has answered. I see some more answers coming in. We still have 1 more minute before we close the polls, so please hurry up if you're taking the quiz. If you're not, why haven't you started? It's not too late to start. Please go ahead. Okay, we have 45 seconds left. I would like as many as have started to complete their quiz before I close it. So please go ahead. If you haven't started, please start. If you want, we can give an extra 30 seconds so that everyone can feel it. Thank you. Okay. Okay, we'll close it in 30 seconds. If you've started, please hurry up. I would like for your answers to come in as well so that we don't cut you off halfway. If you need more time, please raise your hand so that we know that if more people need more time, then I can add a minute. If not, I will have to close the quiz. So if you need more time, can you indicate? Is anyone indicating? I can't see if anyone is indicating. Hold on. Okay. Oh, someone has sent me a message. Okay, fine. 30 seconds more. I received a message asking for 30 seconds more. Okay, so 30 seconds more, and then I close the quiz. So please fill out your questions. So if you have the 30 seconds more, gang, this is your opportunity to finish so that we can move. I still see some answers coming. Okay. Okay. 20 seconds. No problem. This is the last extension I'm giving. Okay, 20 seconds. Someone is asking me for 20 seconds. Okay, this is the last extension. After 20 seconds, we have to close. So please hurry up and complete it, please. I will start the countdown shortly. Okay, we're closing the quiz in, I'm still seeing answers coming in. We're closing the quiz in 10 seconds. Okay, 10, 9, this must be the slowest timer. 8, I'm just buying time for those who want to click the submit button. 7, 6, 5, 4, 3. Who is that last person? Who is that last person? 2, 1, and we have to close the polls. So please go ahead and end the poll. Thank you, everyone. Thank you to everyone who has taken the poll. We will definitely come back to it before the end of the session. And so we're going to jump very quickly into introducing our speakers for today. These are seasoned experts who have graciously put in the time and the effort to join our session today, and they'll be taking us through a number of topics. We will start with Dr. Jamila Garba. She's an obstetrician and gynecologist at Usmanu Danfodio University Teaching Hospital in Sokoto. She has over 15 years of experience, and she's very, very passionate about maternal and child care. Mother's Health Advocacy, and she has published widely, both within local and international journals. She holds an MSc in Epidemiology and Biostatistics from University Putra in Malaysia. Please, a round of applause for our first speaker. I need to see your hands clapping in the chat. If not, she can change her mind. So please put your hands together. A round of applause for our first speaker. Whilst I introduce our second speaker. Our second speaker is Professor Oluseyi Adejumo. He's a professor of internal medicine at the University of Medical Sciences, Ondo City, Nigeria. He is a specialist in nephrology and hypertension, and he has published extensively on chronic kidney disease. He currently serves as Dean of the Faculty of Clinical Sciences and sits on the University Governing Council. Please, ladies and gentlemen, a round of applause for Professor Oluseyi Adejumo, who is one of our speakers, one of our seasoned and distinguished speakers. So I'll introduce the third speaker. Our third speaker is Dr. Hayatu Umar. He's a consultant cardiologist and lecturer at the Usmanu Danfodio University Teaching Hospital in Sokoto. He has 14 years of experience in cardiology. His research focuses on hypertension, peripartum cardiomyopathy, and ischemic heart disease. He's actively engaged in both clinical practice, as we have seen, and cardiovascular research. Please, a round of applause for Dr. Hayatu Umar. Okay, yes, thank you to everyone who is clapping. I was going to say, if you're not clapping, they might change their minds. And our final but not least in any way speaker is Dr. Loretta Michele. I actually asked her yesterday to teach me, 2 days ago, to teach me how to pronounce her name. She's a consultant pediatrician at the National Hospital, Abuja, with a special interest in neonatology, a fellow of the National Postgraduate Medical College of Nigeria. She is certified in neonatal resuscitation and pediatric life support, and is actively involved in medical outreach and volunteering, which is very important. Please, ladies and gentlemen, a round of applause for Dr. Loretta Michele. Please put your hands together. So we will start off with Dr. Jamila Garba, but just before we go, I would inform all speakers the amount of time they've been allotted. For Dr. Jamila Garba, she's going to start off with some cases because we understand the importance of case-based learning. So she'll start off with some cases. She has 20 minutes to go through her session. I would let you know, Dr. Jamila, when you have 5 minutes left. And after each of the sessions, our chairpersons will be able to speak to the different lectures. So after each session, we have 5 minutes for questions, recommendations, comments, but please feel free to put your questions in the chat. The earlier you put your questions, the more chances we will take your questions after her session. We still do have a discussion and question and answer session coming up later on, but for each session, we will take 1 or 2 questions, comments, and some recommendations from our chairpersons. So Dr. Jamila Garba, are you ready? For us to start with you, please take it away. Ma, are you able to unmute yourself? You should be able to. Hi, team. Please allow Dr. Jamila unmute herself.
Okay.
Okay, ma'am. Please go ahead.
Thank you very much. Okay, it's now okay.
Yes, ma'am.
So just to save time, I wish to start on existing protocol to make my presentation on hypertensive disorders in pregnancy. So the objectives of this presentation is to first take a case presentation of some of the common presentation of hypertensive disorders in pregnancy that we encounter in our day-to-day practice. And then we review the classification of hypertensive disorders of pregnancy, highlight the role of antenatal care in early detection of hypertensive disorders of pregnancy, and then discuss the fetal-maternal monitoring, and finally discuss the timing and mode of delivery in women with hypertensive disorders of pregnancy. So the first case is a case of 23-year-old booked prima gravida who presented at 37 weeks gestational age 2 for her routine antenatal care. She was found to have elevated blood pressure of 150/100 and significant proteinuria. So she was examined, and then appropriate investigations were requested, and a diagnosis of pre-eclampsia with severe symptoms and unfavorable cervix was made. She received magnesium sulfate, and then cervical ripening with misoprostol was commenced the day after admission. She progressed to active phase of the labor, and then subsequently delivered a live male baby with ABGA score of 8 in the first minute and 9 in the 5th minute, weighing 3 kg. She remained on admission for 2 days and subsequently discharged home when the BP was controlled. So the second case, as you can see, both of them were prima gravida. This second case is a 19-year-old, but however, she's unbooked prima gravida that presented at 36 weeks gestational age as a referral case from one of the peripheral hospitals on account of multiple episodes of convulsion and admitting blood pressure of 170/100. From the informants, there was preceding history of headache and dizziness prior to the onset of convulsion. And then her Glasgow coma score at presentation was found to be 6/15. She was unconscious. A diagnosis of antepartum eclampsia with unfavorable cervix was made. She was admitted into the pre-eclamptic room. Baseline investigations were requested, and then they were all found to be normal. She subsequently had emergency lower segment cesarean section and was delivered of a live female neonate with ABGA score of 3 in the first minute, 5 in the 5th minute, and 9 at the 10th minute, birth weight of 2.5 kg. Post-operatively, she was still unconscious, but she was not in the anti-intensive care unit, and the baby was not at the special care baby unit. And then she regained consciousness 24 hours after the surgery, and was transferred back to the ward 24 hours later. She was continued on oral antihypertensive and magnesium sulfate, and then subsequently she was discharged. So the two cases are almost similar, but this one was detected early with minimal complication. The second case was presented late with complications. However, we were able to save her life and she was discharged safely. So the main discussion on hypertensive disorder is that we should know that they are the leading causes of maternal and perinatal morbidity and mortality worldwide. And the surprising thing is that 99% of those maternal deaths occur in the low-income countries. And the impact of these hypertensive disorders in pregnancy is lifelong, as they are recognized risk factor for future cardiovascular disease in the mother. They cause about 50% of maternal mortality in adults. In our own maternal mortality review that was presented last year, almost 50%, 48% specifically, were caused by hypertensive disorders in pregnancy. So the classification of hypertensive disorders in pregnancy is almost similar to what we know, just some little variation. If a pregnant woman who is a known hypertensive gets pregnant, she is qualified, the diagnosis of chronic hypertension was made in pregnancy, or if hypertension developed within the first half of pregnancy, she has chronic hypertension in pregnancy. On the other hand, if the elevated blood pressure was diagnosed after the 20 weeks of gestation in a woman who is a normotensive, then the diagnosis of gestational hypertension is made. This gestational hypertension, on the other hand, the next classification is the pre-eclampsia. Pre-eclampsia is diagnosed when the woman has elevated blood pressure and any of these one or more of the following features, which is one of the main things that we need to identify. The first feature is if there is elevated blood pressure and proteinuria, she is qualified to have pre-eclampsia. Secondly, if there is elevated blood pressure with any of the end organ damage dysfunction, then she also qualifies to have pre-eclampsia even without proteinuria. Then thirdly, if there is elevated blood pressure with placental dysfunction in terms of abdominal Doppler or IUR, then she is also termed to have pre-eclampsia. The next class of the classification is chronic hypertension with superimposed pre-eclampsia. In this case, the woman is a known hypertensive, and then subsequently she developed any of these three features and then she'll have chronic hypertension with superimposed pre-eclampsia. Among this, next slide, pre-eclampsia is the most deadly form of all these classes of hypertensive disorders in pregnancy, and is further classified into early onset when the diagnosis ended in delivery at less than 34 weeks, and then it's late onset if it ended up in delivery at or greater than 34 weeks gestation. It's also qualified as preterm pre-eclampsia when there's delivery less than 37 weeks, and then term pre-eclampsia when there is delivery at more than 37 weeks. One important new terminology that has been advocated to be avoided by International Society for Study Hypertension in Pregnancy is that it's recommended that we avoid using the term pre-eclampsia, because the pre-eclampsia, we cannot really predict how fast or the rapidity of the progression. So it's suggested that we should use the symptoms in guiding our clinical management. So we should qualify it as pre-eclampsia with severe symptoms or pre-eclampsia without severe symptoms. So next slide. So the pre-eclampsia is usually a disease of signs, the elevated blood pressure. However, by the time symptoms are developing, usually the disease has gone far, and these symptoms result from endothelial damage, hematological damage, and then also CNS manifestation and renal dysfunction. Eclampsia is one of its complication. Before we qualify eclampsia as a part of the classification, but now eclampsia is a manifestation of the complication of pre-eclampsia, which is one of the commonest complications that we encounter. Is the occurrence of tonic-clonic convulsion in a patient with pre-eclampsia in the absence of other neurological conditions that could account for the seizure. It usually occurs in pregnancy, during labor, or within 7 days postpartum. There are a lot of risk factors, and they have been classified, those for the eclampsia and pre-eclampsia. Those risk factors have been classified into high risk factors and low risk and moderate risk factor. And they are the ones that usually guide us to see who requires more surveillance and close monitoring during pregnancy. These high risk factors are women who has previous history of pre-eclampsia. They have a lifetime risk of having another repeat pre-eclampsia of about 15%. Those who have chronic hypertension, chronic kidney disease, or those with vascular complication like SLE. Moderate risk factors are those who are primary gravida, those with obesity, and family history of hypertension. So another form of manifestation of pre-eclampsia is the HELP syndrome, which is an acronym for hemolysis, elevated liver enzymes, and low platelets. It is one of the subtype of pre-eclampsia with severe features. It also manifests with hypertension, central nervous system dysfunction, and or renal dysfunction. This criteria for making this diagnosis of HELP syndrome is hemolysis, which is evident by lactate dehydrogenase that is more than 600, liver injury from aspartate transaminase that is elevated more than twice, and then thrombocytopenia of less than 100,000 times 10⁻⁹ per liter. So now let's look. How does ANC have a role in detection of hypertensive disorders in pregnancy? So from onset at the booking clinic, baseline blood pressure is measured, proteinuria is assessed, and then the risk assessment is done right at the first booking clinic. Those risk factors assessment will help us to categorize patients into those who are at risk and those who are not at risk. Then with the continuous subsequent antenatal care visits, early detection can be made, which from the symptoms or from the elevated blood pressure. Then the health education also serves as a very good means for the patients to know what are those symptoms that may warrant coming to the hospital. And then routine investigations through the ANC, they can be offered, and then timely referral can be done, and fetal monitoring for those who have developed this condition. Then what are those recommended screening modalities that have been advocated? Surprisingly, one of the most challenging problems with pre-eclampsia is that there is no first or second trimester set of tests that can reliably predict all cases of pre-eclampsia. However, there are various recommendations by the strong bodies, International Society for Study of Hypertension and International Federation of Obstetrician and Gynecology. They recommend the use of combination of maternal risk factors and clinical factors, then also the laboratory measures to actually, and ultrasound, Doppler ultrasound, specifically uterine artery, to use as a marker. However, they are not actually the prediction, the low predictive value. They have all very low predictive value. Other screening modalities that have been recommended is that if women who don't even have the hypertensive disorders, there is recommendation that she should undergo exercise at least 140 minutes of brisk walk in a week, even undergoing the daily house chores and activities may help in maintaining a good healthy diet, a good healthy lifestyle, so that those diseases cannot develop. And then those women who have had been labeled as risk of developing pre-eclampsia, if they have one high risk factor or they have two moderate risk factors, the recommendation is that they should be given prophylaxis with aspirin. It delays the onset of the pre-eclampsia. So recommended dosage of 150 milligram started at less than 16 weeks, preferably usually from 12 weeks of gestation, and it should be stopped by 36 weeks of gestation. Another recommendation for the prevention is for those who are at risk is to give calcium supplement of at least 500 milligram per day, even in cases where low detection cannot be traced. So how does the next important aspect we should consider is how does the hypertensive disorders impact on the maternal outcome? It has serious maternal complication and fetal complication. Some of the immediate complications that we can see is maternal mortality. It can result in all the end organ damage, the kidneys, the liver, the urological complication, are also obstetric complication in terms of abruptio placenta, fetal demise, and preterm delivery. Some of the late complications that can occur include cardiovascular disease later in life, renal disease, recurrent hypertensive disease in future pregnancy, and then also it affects the mental health in terms of post-traumatic stress disorder, depression, and anxiety. So having identified the patient with hypertensive disorders in pregnancy, the most important is maternal and fetal monitoring so as to reduce the morbidity and mortality. So the parameters to the use in monitoring women with hypertensive disorders in pregnancy, number one is blood pressure measurement. It's very critical. For those on outpatient management, they should be measured at least daily, while those for inpatient, depending on the severity, will go to the extent of hourly BP monitoring. Urinalysis also is very important. However, once the diagnosis has been made with urinalysis, it doesn't have much significance in monitoring the severity or even the prognosis. Other important tests that are important includes the test for the end organ damage, EUCR, uric acid, clotting profile, liver function test. All those ones are very important. And the review of symptoms so as to detect those symptoms of severity early, then weight and weight measurement. The fetal monitoring include fetal movement count by the mother, ultrasound scan to monitor fetal growth, and also the amniotic fluid. Doppler ultrasound is very important and is one of the earliest features that can be detected, that can detect any uteroplacental impairment. Then non-stress test also very important in detecting any fetal heart rate abnormality. Biophysical profile may not be an early, may not detect early insult. Usually by the time the biophysical profile is affected, the disease has gone very progressive. So Doppler is very important in early detection. Then the most important thing is delivery so as to have a live fetus. Antihypertensive therapy is one of the most important aspects in management of hypertensive disorders in pregnancy. And the first-line therapies for antihypertensives include labetalol, nifedipine, and aldomet. However, there is no strict rule to say this is the best among them. The one that the physician is conversant with, safe in pregnancy, and has been given us good outcome among these ones is advocated. Nifedipine usually is preferred as medication for acute oral treatment, while it is IV labetalol, or IV hydralazine can be used. Amlodipine has not been reported to have any associated birth defect, hence it can be used. Those antihypertensives that are not safe in pregnancy are the AC inhibitors, angiotensin receptor blocker, minocorticoid, and antracolate, and nitropuroside. These ones are not safe in pregnancy and are not advised to be used in pregnancy. Another form of management apart from the antihypertensive is prevention of convulsion or treatment of convulsion, which is one of the commonest complications of severe pre-eclampsia. Next slide, please. So magnesium sulfate is indicated as the, next slide, please. Am I with you? Am I audible?
Yes, you are.
We can hear you.
Okay. So the controlling the silent will continue. So another form of management that is important is the magnesium sulfate. It is used to prevent seizures and also used to treat seizures. It's the gold standard for both prevention and treatment. Then steroid therapy is indicated when there is fear of prematurity, and then it's advocated that steroids should be given when there is need for delivery at any gestational age less than 34 weeks. Some of those features I am at the slide of pre-eclampsia with severe features. Just a little bit backwards a little so that the audience can follow very well. The previous slide, please.
Slide 44.
No, okay. Okay, to the next one. The next one. Okay. So magnesium sulfate. So some of the features to consider for before when delivery is whenever a woman is having those features of severity: intractable headache, persistent vision changes, blurring of vision, right upper quadrant pain, pulmonary edema, progressive thrombocytopenia, progressive abnormal renal and liver enzyme, and also when there is non-reassuring fetal status, meaning that the fetus is already in distress. So this was needs delivery. Then the next slide. So when do we deliver? That's the next thing. When do we deliver? Actually, once the diagnosis of pre-eclampsia is made at pre-viable age, the standard recommendation is to terminate the pregnancy. Issues arise when we diagnose pre-eclampsia with severe symptoms at gestational age after the age of viability before 37 weeks. So preferably the general mode of delivery is usually vaginal delivery until when there is another obstetric indication. But pre-eclampsia per se alone may not be an absolute indication. So when there's once a woman with pre-eclampsia with severe features has reached 37 weeks gestation, it's recommended that she should be delivered. However, the attention should be more towards the mother. We should choose the life of the mother in priority more than that of the fetal maturity, because she has to be alive for her to take care of the children and for the child to be alive. Then immediate delivery once there is unstable maternal or fetal condition. For cases of gestational hypertension, once they have reached 37 weeks gestation, it's advocated that they should be delivered. In cases of even chronic hypertension, they should also be delivered before they get to 40 weeks gestation, even if they don't have symptoms of severity. So let's move to the next slide. Updates in the management. Previously, the understanding is that once a woman with pre-eclampsia with severe features has been delivered, the disease has come to an end. But it has not been found that despite the delivery, some changes, so the insult is still there and organ damage might still continue. And there is need for us to continue meticulous management as in the postpartum. Usually the cases that usually even arise intrapartum or especially postpartum cases of pre-eclampsia, they need to be more deadly. Thereby, there is need for aggressive post-delivery management in all cases of pre-eclampsia. So before one of the important things that we need to understand is what we need to understand is the delivery is not definitely the end. So there is need to continue magnesium sulfate, even antihypertensive after the delivery. So by now, I think we can go and have a look and see what are those key points from all this discussion that we have had from beginning. The etiopathogenesis, even though we didn't have much discussion on the details, but the main problem is that it's multifactorial. There are a lot of this, and it's multisystemic. And pre-eclampsia is usually defined as pre-eclampsia with severe symptoms and also pre-eclampsia without severe features. Antihypertensive therapy is usually indicated for cases of elevated BP. And then the preferred first-line antihypertensive are nifedipine, labetalol, methyl-dopa, and then magnesium sulfate has been recommended as the gold standard for prevention and treatment of delivery. Delivery for now, we can say is ultimate care. However, we should know there is need for aggressive post-delivery management. and we should investigate and watch out for the deadly complications of pre-eclampsia, which are eclampsia and HELLP syndrome. There is a slide that I didn't add in this slide before the conclusion, which I can just briefly explain, is the challenges. Despite having all this knowledge in the pre-eclampsia, definitely, as some of us might be surprised, why are people dying despite that we have knowledge, we have the expertise in management of these hypertensive disorders in pregnancy. So some of the challenges that we encounter in our day-to-day practice is that late antenatal care booking. Most patients don't book early for early detection to be made and for prompt preventive measures to be instituted, even for those with high risk. And then for those who even come for the pre-booking, they have poor health-seeking behavior. Some don't come for the antenatal care clinic the way they should. And then some, because of poverty, they miss their antenatal visit. We still face some socio-cultural misconception about eclampsia in our environment. Some believe that it's spiritual. They don't believe that it's something that can be managed in the hospital. So that challenge usually delayed presentation to the hospital until when all measures, traditional medications have been tried. By the time they come to us, and organ damage has already started. In terms of in the hospital, some of our challenges, the limited screening tools that are available, and then for those screening tools that are available, the low predictive value of those screening methods pose a challenge for us in the management. And then by the time patients are referred to us, because at the referral hospital, most of those patients, they don't receive care because the staff at the peripheral hospital don't have more skills to actually provide the prompt management. Late presentation, delay in referral also makes it very difficult for us. So by conclusion now, we can say that we have discussed and have seen that hypertensive disorders in pregnancy, they are major cause of maternal and perinatal morbidity and mortality in our environment. And it's very difficult to predict all cases. And then, however, with early detection, prompt management, these are the key in reduction of maternal and perinatal morbidity and mortality. Hence, we suggest that there is need to invest more in research to detect, so that early detection markers that can detect pre-eclampsia early should be identified, so that timely intervention is given. And I want all of us to go back home with the notion that with every antenatal care visit that we do judiciously, there is possibility that we can save lives through identification of pre-eclampsia early. Thank you very much for listening. This is what I...
Thank you so much. Thank you so much, Dr. Garba. This was so enlightening. Can you hear me? Just
Yeah, we can hear you, Adora.
Okay, great. Because I see Dr. Garba is frozen just at the end of her session. Thank you so much, Ma, for also sticking to the allotted time. Truly grateful for that. We did give her a little bit extra time because she was going to speak on some of the cases. So we'll hand over to Mr. Chairman, sir. Dr. Oni, to please take it away for the discussions, comments, recommendation. If we have enough time, we'll take 1 or 2 questions. Please go ahead, sir.
Thank you so much, Dr. Adara, Mrs. Moderator. Thank you so much. I think the presentation on hypertensive disorders of pregnancy taken by Dr. Garba has been a very enlightening one and educating. Starting, I will just quickly give a summary of what has been presented and the highlights, so that they will go to the question and answer. I know 1 or 2 questions have been posted on the chat. So, but from what has been presented, I think the clinical scenarios actually that have been presented by Dr. Garba, they've represented some of the clinical cases, some of the patients that we manage in our health facility. Thank you for selecting these cases. And we need to take note of the peculiarity of these cases. Number one came as an unbooked patient, the other came as booked patient, and that makes a lot of difference in their presentation. The one that came as an unbooked patient presented late, and which actually constitute one of the challenges that we face as an obstetrician in managing those cases. So then from the cases, we can also identify the risk factors in them, primary gravida, and some of the other risk factors. Teenage pregnancy is a risk factor in them. Other risk factors have been mentioned in the course of presentation, so I don't need to repeat that. Emphasis is being laid on also on the burden of this disease. It has actually constituted 99% cause of maternal mortality in low and middle income countries. And this is quite huge. And I think this is very important and is a challenge for the society and the obstetricians and everybody concerned to really wake up that while we're managing and we're trying to reduce the effect, the burden of obstetric hemorrhage as a cause of maternal mortality, hypertensive disorder is taking over again to cause the damage and havoc to some of our women. As far as UCH data is concerned, our previous maternal mortality review audit done for 2024, we noted that 56% of our maternal mortality was actually due to hypertensive disorders of pregnancy, and which is similar to the data presented here. And I'm very sure that is probably what we're going to have in other tertiary health facility too. So well, I also like the classification. Yes, the emphasis is being laid on the classification there. Now, the new classification that pre-eclampsia should be regarded based on also the severity, pre-eclampsia with severe features and those without severe features. I think is very important also to take note of this. In order not to waste our time, a lot have been said on this. So because of other speakers, I think we should take the question and answer. I have some hands being raised, but there are some questions that have been posted. Yeah, the first questions, that's from Akinwale Alufa. How best can we manage this situation in places where there are no doctors? Dr. Garba, I think can you answer the question?
Team, please make sure that Dr. Garba is able to unmute herself.
Okay, thank you very much. I think it depends. There is one of the things that we don't have a lot. If the doctor is the best person to manage a pre-eclampsia patient, however, the fact that we know magnesium sulfate can be given, antihypertensive can be given, delivery nurses, if it's vaginal delivery, they can offer vaginal delivery. Even choose midwives, they can offer them that. So I think at primary health care centers where we don't have enough doctors, we can extend our community service to ensure that all those labor staff in the labor ward are skillful in giving magnesium sulfate. First, it should be available. They should have formal training on how to give magnesium sulfate, antihypertensive for the emergency and also the maintenance. And then they should be taught how to refer early, because they may need intensive care unit admission and ICU admission. So they may not be completely managed in peripheral hospitals that is not actually a standard tertiary hospital. So I think they should it's better managed in a facility where we have specialists than in primary health care centers. So I don't know if you have any other different opinion.
Thank you so much, Dr. Garba. I think the question has been well answered. As a matter of fact, because hypertensive disorders of pregnancy is a multisystemic disease and affect different organs of the body. Usually, it will entail different specialties, and that's probably the basis why we've even invited different speakers here. So usually, these specialists are not available at primary health facility. Then also some of the even the facilities that we need, some of the things we need, the neonatal unit, the intensive care unit will not be available. Some of the tests that will be done, even to evaluate the severity of this, will not be available. So it will be appropriate, as Dr. Garba has been said, to refer those patients. However, before you refer, you should actually you should initiate a resuscitative measure, which include you should give a loading dose of magnesium sulfate. It's very important. You should also give an antihypertensive, which has rightly been said, labetalol is effective. That can be given as an IV and can also be given as an oral medication. While IV magnesium sulfate only comes in intramuscularly or can be given as an intravenous. So, and we have different regimen of that. So at least the starting dose of all this can be given, and patient will be educated and referred. Why? Because sometimes you want to refer some of those patients and they refuse, and because of the logistics, you need to lay emphasis on the reason why they need to be referred to have a better maternal and fetal outcome. So thank you for. Let's go to the next question. When treating patients with pre-eclampsia using magnesium sulfate, what is the best regimen to apply? Dr. Garba.
Okay, thank you very much. The best regimen of magnesium sulfate is still actually a field under study. There are various research ongoing. So what we should have in mind is that the magnesium sulfate is the gold standard. So based on our preference with our practice, what we are used to, we can have an idea, is this really working for us, or do we go and look for other centers? What are they doing? There are various research, ongoing research that are ongoing. What we do in our center, the Sokoto regimen, has been giving us a good response. We use the modified pre-charge regimen. We give the loading dose of 14 grams, and then we give maintenance of 5 grams 4 hourly for 3 doses, or until 12 hours after delivery, or until 12 hours after that episode of convulsion. And it has been working for us since it's available. Other ones that, like the Zuspan regimen, has also found to be effective. The actual pre-charge regimen is also effective. The difference with what we do in our sentinel dose doesn't stop at 12 hours. So if you are in a facility that you have the availability of magnesium sulfate, you can still go with the actual pre-charge regimen, which I think it should be okay. I hope it's clear.
Thank you so much. Thank you, Dr. Garba. Yeah, let's move to the next question. I think probably this will be the last one.
Hi, sir. We can only take, we will take more questions towards once we finish all the sessions, but for each of the sessions, we only have room for one question, and then the chairperson will also coordinate that so that we can ensure that we get the other lectures within the time.
Okay, thank you so much. So we'll probably take the next question, the set of questions that have been raised during the general discussion.
Yes, sir. We've compiled them and we'll bring them up during the general discussion. Yes, please.
Thank you so much.
All questions are being noted. Thank you so much, sir. Okay, so we'll be moving on to the second speaker for today. Thank you to everyone who has sent in your questions. We are compiling them and we'll bring them up during the general discussion. So we'll be moving on to the second lecture for today by Professor Oluseyi Adejumo. Please, a round of applause as he takes over the mic to speak. Please go ahead, sir.
All right, thank you so very much for having me, and good evening to everyone. So I'll be talking about generally about the nephrology perspective to management of hypertensive disorders of pregnancy. Next slide, please. So hypertensive disorder of pregnancy is an important cause of maternal morbidity and mortality globally, and the burden is actually higher in sub-Saharan Africa. The risk factor includes hypertension, diabetes mellitus, obesity, chronic kidney disease, multiple gestation, autoimmune disorders such as antiphospholipid syndrome, systemic lupus erythematosus, fetal trisomy 13 in index pregnancy, nulliparity, advanced maternal age, family history of pre-eclampsia, use of assisted reproductive technique, and adolescent pregnancy. And if you look at those risk factors, we found out that some of those risk factors are actually cardiovascular risk factors, such as hypertension, diabetes, dyslipidemia, obesity. Now, going to the pathogenesis of pre-eclampsia, it's an interplay of both maternal and placental factors. And summarily, what we have is there is defect in trophoblastic differentiation. Ideally, during the early trimester, the first trimester, there should be a differentiation of the trophoblastic cell from the proliferative type to the invasive type. But this does not happen in those that have increased risk of developing preeclampsia. So you have defective trophoblastic differentiation. So what you now have is that the normal process is that there should be invasion of the trophoblastic cells into the decidua. From decidua, it moves into the myomectron. Then from there, it moves into the endothelium. Then from there, the cells migrate into the tunica media, such that with time, there's a transformation of the spiral artery so that it has higher capacitance and the resistance is reduced. And with these properties, they can be adequate or improve blood supply to the placenta bed. But this does not happen in those who have increased risk or some other risk factor for preeclampsia. So you have defective transformation of spiral artery such that there is reduced perfusion to the placenta. And also another contribution is also maternal immunologic intolerance. The antibodies of the mother is like intolerant to fetal antigen or paternal antigen. So there is like host versus graft reaction, and there is a rejection. So you have that pattern eliciting inflammation and causing placenta injury. So this slide speaks to the pathogenesis, and it explains. We can see that we have some obstetric complications such as in those that have multiple gestation, those that have identiform mole, there is increase in the placenta mass without commensurate increase in the blood flow to the placenta bed. So this will lead to what? Will lead to placenta hyperperfusion. Also, those that have some cardiovascular risk, like those that have hypertension, those that have diabetes, those that have obesity, there's also, it affects the blood vessels. So there is reduced perfusion to the placenta bed. So there's placenta hyperperfusion. Once there's placenta hyperperfusion, there will be placenta ischemia. With placenta ischemia, there will be a cascade of oxidative stress. And as such, there will be increase in factors that are angiogenic, such as increased level of soluble endoglin, soluble FMS-like tyrosine kinase 1. Then there will also be a reduction in pro-angiogenic factors, especially placenta growth factor and vascular endothelial growth factor. This will lead to ischemia, and this will lead to endothelial dysfunction in the maternal circulation. And as such, there's release of vasoconstrictor. So there is widespread vasoconstriction of the vessels, and which will lead to activation of renin-angiotensin pathway, which will lead to increase in the blood pressure. Subsequently, we also have this vasoconstrictive effect in other organs, in the brain, in the liver, and in the kidneys. And that's why you can have other multisystemic manifestation. You have central nervous system manifestation, you have liver dysfunction, and you can have acute kidney injury. And in those that have background chronic kidney disease, there can be worsening renal function, which we know as the acute on chronic kidney disease. Next slide, please. So this slide speaks to the bidirectional relationship between preeclampsia and chronic kidney disease. And like I mentioned earlier, you can see that there are some factors that are common to both, some risk factors that are common to both disease entities. For example, hypertension, diabetes, dyslipidemia, obesity are risk factors for both chronic kidney disease and preeclampsia. And as such, there is a relationship between the two disease entities. They share some common risk factors. Also, too, the underlying pathophysiology of both conditions are also similar, and there is a basic underlying pathophysiology of both disease entity, which is endothelial dysfunction. So in chronic kidney disease, you have endothelial dysfunction. In pre-eclampsia, you have endothelial dysfunction. And at the glomerular bled, you have endotheliosis. So what are the factors that will lead to endothelial dysfunction? Complement activation. Remember, I talked about immune intolerance in the mother, maternal immune intolerance. There will be impaired angiogenesis. There will be activation of the renin-angiotensin pathway, which are pathophysiologic mechanisms in both disease entities. All this will lead to endothelial dysfunction, which are common to both conditions. So it will manifest in the pre-pregnancy state as chronic hypertension, proteinuria, and during pregnancy, in those that have increased risk, there can be worsening proteinuria, there can be loss of maternal kidney function, or those that have pre-existing kidney disease, they can be worsening, and there can be an acute on the background chronic kidney disease, which can affect fetal outcome. There will be fetal growth retardation, restriction, preterm delivery, low birth weight, and there will be an increased need for the neonatal admission with sequelae. Also, in the postpartum period, you can have increased cardiovascular risk. Such patients can develop chronic hypertension. Some of them can develop TM later in life, and they have increased risk of cardiovascular disease and death. And also the risk of kidney failure is also high in them. So what are the renal complications or sequelae of pre-eclampsia? One is acute kidney injury. In fact, up to 6 to 15% of these patients can develop acute kidney injury. A systematic review by Kripo and his team showed that 6% of those with pregnancy-induced hypertension in Africa will develop acute kidney injury. Higher value has been reported in the United States of America. Also, too, an individual who has a pre-existing chronic kidney disease, once they have a superimposed pre-eclampsia during pregnancy, there can be rapid progression of the chronic kidney disease. They can move possibly from early stage to stage 3 or 4, and some of them can even progress to end-stage kidney failure. Also, too, chronic kidney disease, especially proteinuric chronic kidney disease, diabetic kidney disease, and hypertensive kidney disease, are sequelae of pre-eclampsia in those that have high risk. A study by Barrett et al. Showed that hypertensive disorder is associated with increased risk of maternal chronic kidney disease, particularly hypertensive or diabetic forms of chronic kidney disease. Also, the risk is higher, especially in those that have preterm pre-eclampsia, those that have recurrent pre-eclampsia, and a pre-eclampsia complicated by pre-pregnancy obesity. Therefore, women who experience hypertensive disorder may benefit from future systematic renal monitoring. Next slide, please. This slide shows the renal sequelae of patients with pre-eclampsia. And we can see here that there is increased risk of acute kidney injury in those with pre-eclampsia. They have about 1.3 times higher risk of developing AKI within 5 years of having pre-eclampsia. But more importantly, we can see that the hazard ratio for developing chronic kidney disease is actually higher, about 6.1 times higher when they have pre-eclampsia. Within 5 years of the pre-eclampsia, they can develop chronic kidney disease. But more importantly, they are more at risk of having hypertensive kidney disease, as well as glomerular and proteinuric kidney disease, as against chronic tubulointerstitial nephritis. Next slide. So what are the important ways of managing individuals with pre-eclampsia? Number one is that we must have at the back of our mind that the principle, as earlier mentioned, is that we want to limit the risk to the mother while also trying to get a baby that has fetal lung maturity, but not at the expense of the mother's life. So you have that at the back of your mind. So number one is that management will involve early delivery of the baby as soon as possible, because the underlying pathophysiology has to do with the placenta. So once whatever you do and the placenta is not out, you are not still achieving proper management. You can only use that to buy time. So one of the things that is key is, as much as possible, while you weigh the options, management will involve early delivery of the baby as soon as possible. Also, magnesium sulfate is only indicated in those with severe features. those with severe features. So it's not, magnesium sulfate is not a blanket management for patients with eclampsia. Those with severe features will be the ones that will benefit from magnesium sulfate, and obviously those that have eclampsia. Also too, there have been a lot of debate about what is the cutoff to initiate blood pressure management in terms of using antihypertensive management. But from the studies and the widely accepted consensus is to commence oral antihypertensive medications once BP is persistently equal or greater than 140/90 of millimeters of mercury. Studies have shown that at this value, the likelihood of compromising placental blood flow is limited. So once the blood pressure is 140/90 and is persistent, it's safe to introduce antihypertensive. And what are the antihypertensive of choice? Number one is nifedipine, labetalol, metildopa. They are the ones that are safe in pregnancy. However, nifedipine has, among all these antihypertensive, nifedipine has a lot of studies that have shown that it is the most safe in pregnancy. Of course, labetalol is also safe, metildopa is also safe, but in terms of data favors nifedipine even when you compare it to labetalol or metildopa. Also too, at times you may also need to use low-dose thiazide diuretic. Thiazide diuretic has been found not to be teratogenic, but there are special reasons why you want to introduce low-dose thiazide diuretic in those that have volume-dependent hypertension, such as patients with heart failure, patients with kidney disease. You would do well to introduce a low-dose thiazide diuretic if you're not achieving adequate control. Now, severe hypertension in pregnancy, when you're talking about pregnancy, hypertensive disorders of pregnancy, we use a cutoff of equal or greater than 160/110 meters of mercury as against 180/110 of meters of mercury in non-pregnant individuals. So we should have that at the back of our mind. Once the blood pressure, systolic blood pressure is up to 160, you are dealing with severe hypertension in hypertensive disorders of pregnancy. And in such individual, you could either institute intravenous labetalol or intravenous adrenaline if you can secure an IV access. However, if you are unable to secure an IV access immediately, you can also use oral immediate release nifedipine. Can also be used in such patients. So we should have at the back of our mind that best practices says that in severe hypertension, you want to use oral immediate release. There are different forms of nifedipine. But if the patient has, if it's just the mild form and the blood pressure is not as high as 160/110, then it's preferred to use the extended release nifedipine. Now, for some patients, even when you've introduced the IV labetalol, you've used IV adrenaline, you've used maximum dose, or the patient is beginning to show adverse reaction or side effect of the medication, if it's available, you can also switch to intravenous nicardipine in managing the patient if you have suboptimal blood pressure control response in those you are giving IV labetalol and IV adrenaline. Next slide, please. So this slide just speaks to, just like an algorithm to guide us when you have severe hypertension and you are dealing with severe hypertension in hypertensive disorders of pregnancy. So what things to consider is, can you easily secure an IV access? If you can do that, then you start the patient with IV labetalol, and the slide shows how you can titrate upward, bearing it in mind that you cannot exceed a maximum dose of 300 milligrams daily. Or in fact, some patients may not even get up to 300 milligrams daily, but they're already having some side effect, maybe having bradycardia. So you need to consider other options. So you can start with intravenous labetalol. Then you can, if the patient is not still getting adequate control, you can go ahead and use IV adrenaline. If the patient is not still getting adequate control, if it's available, you can use intravenous nicardipine. Also, if for any reason you are unable to get an IV access immediately, like I said earlier, you can use immediate release nifedipine orally. Then you can continue managing the patient. Next slide, please. So for how do you follow up, especially those that have pre-eclampsia? Now, you follow up blood pressure is very important, even post-delivery. It's very important in the sense that even what's been found out that within 2 weeks, usually the blood pressure would come down. And even for the matter that a patient has pre-eclampsia, a patient can still develop eclampsia even 2 weeks postpartum, usually early 2 weeks, up to 2 weeks, up to 6 weeks postpartum. But most of the sequelae or most of the complications or adverse complications would occur in the first 2 weeks. So a very close monitoring of the blood pressure in the first 2 weeks is very, very important. Also, too, you must regularly see those patients and follow them up with urinalysis to assess proteinuria. Also, too, regular assessment of kidney function. And we should not only limit it to looking at the value, is the value within the reference value. We should have at the back of our mind that normal physiological response in pregnancy, usually there's hyperfiltration, and as such, the creatinine value goes down. So you can actually have a creatinine value within the reference value in a patient that has kidney impairment. So we should have that at the back of our mind. So a normal value of creatinine in such patient does not exclude an acute kidney injury or chronic kidney disease. And you can also estimate their eGFR and you can monitor them. Also follow up for early detection and management of some cardiovascular risk factors like diabetes mellitus, cardiovascular disease, and chronic kidney disease. Also, too, for any patient that has had, or any woman that has had pre-eclampsia, there is a higher risk of developing pre-eclampsia and its complications in subsequent pregnancy. As such, you must do a comprehensive antenatal care in subsequent pregnancy. It also entails taking adequate history, doing a risk evaluation in that woman that has come for antenatal care, so that you can know, is this person high risk or low risk, and you can manage accordingly. Also, it's also important to do a preconception counseling, especially for those with chronic kidney disease. And this should involve a multidisciplinary team involving obstetrician and nephrologist, because once a woman that has CKD develops, gets pregnant, there are implications. The pregnancy can worsen the kidney function of that individual, and that person, possibly that woman has been in stage 3, it can worsen and get to stage 4 or even stage 5. Also, too, the likelihood of developing pre-eclampsia, eclampsia is also high in them. So also, optimal preconception management of hypertension, diabetes mellitus, obesity. We shouldn't wait until a woman gets pregnant that we start treating the hypertension, especially those that have chronic hypertension. Every woman that comes to our clinic, let's add at the back of, especially in the reproductive age, that this person is at a higher risk of developing pre-eclampsia. So we are very proactive in managing their blood pressure, managing their diabetes, giving dietary counseling, lifestyle modification to address their obesity. Regular and comprehensive antenatal care, like I said, taking comprehensive history and evaluating high-risk individuals. Early diagnosis and treatment of pregnancy-induced hypertension. And this also brings to the fore the need for us to ensure that our women, they go for antenatal care early. And when they go for antenatal care, basic comprehensive evaluation, urinalysis, blood pressure, so that once the blood pressure is going up, you can know that, oh, this person will likely develop pregnancy-induced hypertension. And also, even though we said that the blood pressure cutoff when you want to start hypertensive is when the blood pressure is 140/90, but we should also have at the back of our mind that it's not absolute, it's not an absolute cutoff. For those that have a relatively low blood pressure at the onset of booking, maybe like 90/50, and the person is having 130/80, that's a significant rise. And such a patient may require treatment. So also, early institution of medications such as low-dose soluble aspirin and calcium supplements have been found to reduce the risk of pre-eclampsia in those that have high risk, and it should be started early in the course of the pregnancy, usually before 16 weeks of gestation. And some people have advocated that by the time you get to 36 weeks, you can decide to stop, because to reduce the risk of bleeding, especially if the patient would go for surgery. What are the social cultural barriers or factors that you would have to deal with in managing such patients? Number one is illiteracy. Illiteracy, most of our women, they book late. Some don't even come for antenatal care, low socioeconomic status. They don't even have money or what it takes to get a comprehensive healthcare. Teenage pregnancy, harmful cultural beliefs, such as stigmatizing those that have had seizure. So a woman who has had seizure in pregnancy, because of the stigma, may be reluctant to volunteer that information when he's coming for subsequent antenatal care in subsequent pregnancy. So we need to address those factors so that we can improve outcome of our women during childbirth. Also, there are some economic factors or factors that are related to poor economy, such as poor road network, because at times the woman may need to travel some distance to get to where he will get a good care, inadequate health facilities, inadequate human resource for health. A number of our primary health care facilities, they don't have functional speak, they don't have strips to do urinalysis. A study done about 2 years ago showed that most of our primary healthcare centers, they don't have functional speak. So we need to address those factors so that we can improve the outcome of our women, especially during pregnancy. Next slide. Next slide, please. So how do we address these barriers? Number one, health education to create awareness. Every woman, as much as possible, should know that when they are pregnant and when they go for antenatal care, basic things that should be done, among other things, not only looking at doing the ultrasound to know the sex of the baby, they should have their blood pressure checked, and they should have an idea. Even if you cannot know the value, is it normal or it's not normal? So that in subsequent antenatal care, if the blood pressure value is going up, you would know, and you would know that this person will require more proactive steps to be taken in managing them. Also, disease-specific education. We can leverage on social media to educate people on the early signs of pre-eclampsia. Let it be on billboards. Let's use mass media to educate the masses to know about pre-eclampsia. It's been established today that pre-eclampsia is a major cause of maternal mortality in Nigeria. But it's not, I'm very sure that most people do not know this. So we need to sing it to people, let them know that this is a problem. What are the early signs? So that once they start seeing those warning signs, they can present early. There's a need for us to do a strong advocacy with policy makers and governments so that they can implement policies that will address these problems. Overall, there's a need for us to improve and overhaul our healthcare facility. Let them have adequate people to manage this patient, nurses, choose adequate training for them, basic facilities that they need to be able to manage this patient. Good referral system would also be helpful in addressing the social cultural barrier to managing patients with pre-eclampsia. Next slide. Okay, these are some of my references. So in summary, in terms of pathogenesis, the placenta plays a major role, and it's a combination of a number of factors, both maternal and fetal factors that interplay. Now, there's a relationship between chronic kidney disease or kidney disease as well as pre-eclampsia. They share an underlying pathophysiologic mechanism, endothelial dysfunction. Secondly, they also share common cardiovascular risk factors, hypertension, diabetes, obesity, dyslipidemia. It's very important that we would educate the masses on early signs of pre-eclampsia. Also, comprehensive antenatal care. There's a need for us to create awareness, let the government know that this is a problem, this is a major cause of maternal mortality and morbidity, so that we can educate our women. They need to attend antenatal care early, and also too, health workers, what are the basic things that must be done so that we can recognize this problem early and we can address it. Also important for us to involve the physician, cardiologist, nephrologist, and obstetrician in planning, even before a patient that has high risk, especially chronic kidney disease, before they get pregnant. Let them know what are the possible sequelae, and we can adequately counsel them. Thank you so very much. I want to appreciate the Nigerian Hypertension Society for giving me this opportunity to do this talk. Thank you so very much.
Thank you so much, sir. And thank you to everyone who has sent in questions in the chat. We are compiling them. We will, at this point, like to call on our chair lady, Professor Hadiza, to give us her comments, her recommendations for this particular session. Over to you, ma'am.
Thank you so much, Prof. Adejumo, for this beautiful presentation and given much more insight as the nephrologist point of view. During the course of his presentation, he further highlighted the risk factors for pregnancy-induced hypertension, in-depth of the pathogenesis of pre-eclampsia. He also highlighted on the association between chronic kidney disease and pre-eclampsia, having shared the same risk factors and having shared the same pathogenesis, that is endothelial dysfunction. He also highlighted on the renal complications of pre-eclampsia, which range from acute kidney injury to acute or chronic kidney disease, to progression of a pre-existing chronic kidney disease to an advanced end-stage kidney disease. He also reviewed the management of pre-eclampsia as being discussed by the previous speaker, the gynecologist, And then he emphasized and gave an algorithm, a very important one, on detailed prescription of antihypertensives and how to up-titrate them in severe cases. He also reminded us on the recommendation of when to intervene control of blood pressure, as to when the blood pressure systolic greater or equals to 140 or and diastolic greater or equals to 90 millimeters of mercury. He further also highlighted on the role of follow-up in patients with kidney disease and pre-eclampsia. The importance of blood pressure control cannot be overemphasized. And of course, there is need for regular monitoring, urinalysis for proteinuria, so as to ascertain for progression, and also regular assessment of kidney function. Again, he highlighted the importance of prevention. Preventive measures are very, very important in management of such illnesses. And then preconception management is also very important in patients with pre-existing hypertension, diabetes, and obesity. The importance of regular antenatal visits, early and regular, has also been emphasized because this will aid early diagnosis and treatment, which will prevent development of complications. He also discussed barriers to prompt diagnosis and management, both sociocultural and economic factors, which are really riders to morbidity and mortality for hypertensive disorders of pregnancy. Thank you so much for this wonderful presentation. We'll have a look at one or two questions that are already there. And the first one is talking about the use of sublingual nifedipine, whether sublingual nifedipine has a role in the management of severely elevated blood pressure. Prof, there's a question asking whether
Thank you, ma'am.
has a role.
Yes, ma'am.
Hypertension.
Thank you very much, ma'am. Sublingual nifedipine does not have a role in management of pregnancy-induced hypertension or pre-eclampsia, and also in all cases of hypertensive urgency or hypertensive emergency. And the reason is that sublingual nifedipine, the absorption cannot be predicted, and also the tongue is highly vascularized. And the drawback is that you can have erratic action, such that you can have a sudden crash in the blood pressure, which can also lead to other complications like hypoperfusion to the organs, which can lead to stroke, can lead to watershed infarct, and it can affect the other vital organs, and even it can significantly compromise placental blood flow. So summarily, sublingual nifedipine does not have a role in the management of preeclampsia or in any other hypertensive emergency. Thank you.
Thank you, Prof, for this response. So sublingual nifedipine is no longer recommended for use in any form of treatment of hypertensive emergency. It rather gives a more delirious and more hazardous effect than being beneficial. He had already highlighted the drug treatment for severe hypertension in pregnancy as the IV medications, intravenous labetalol or intravenous hydralazine, and he had given us the beautiful chart and a guide on how to use these agents and how to up-titrate them. Thank you so much, Prof. The next question is on the dose, that what is the dosage of nifedipine for elevated blood pressure? This is the question. The dose nifedipine in elevated blood pressure.
Yes, so usually in management of hypertension, usually you start with a mild to moderate dose that you can escalate depending on the response. So it also depends on the type of nifedipine that you are using. So you can give nifedipine as 20 milligrams BD, or you can make it 20 milligrams TDS, and you can also make it 30 milligrams TDS. And if you're also using the extended release, so you can give it 30 milligram XL, you can make it 60 milligram, you can titrate to 90 milligram XL. So it's the basic principle. You start with something with a moderate dose, and you gradually titrate upward depending on the response. However, we should also have at the back of our mind that the higher you go, the more likelihood of complication, and that's why the dual combination therapy comes in. So instead of titrating upwards, getting to the maximum dose of nifedipine, you can introduce labetalol. So you can have two different drugs acting at two different levels, and that would achieve better control, will minimize side effects.
Thank you. Thank you so much. So the rest of the questions will be entertained at the end of the presentations. Thank you. Over to you, please.
Thank you so much, Prof. Thank you. We will move to the next lecture by Dr. Hayatu Umar. Sir, I'm going to pause you when you have 5 minutes left, but you have in total 15 minutes for your session, and then we'll use 5 minutes for the recommendations before we jump into the next session, and then we'll do the question and answer and discussions. Can you hear us, sir? Hi, Dr. Hayatu Umar. Can you hear me?
Yes, ma'am.
Okay, over to you, sir. Well done, sir.
Okay. So, my respected society, my respected teachers and mentors, my respected chairman of this webinar, and also the chair lady of this webinar, my respected senior colleagues, and my respected members of the Hypertension Society, local and international. Good evening to you all. So it's my pleasure to present this to this gathering, hypertensive disorders in pregnancy, under the following headings. Permit me to stand on the existing protocols. So I'm going to discuss hypertensive disorder under the following outlines: introduction, epidemiology, then cardiac adaptation in normal pregnancy, long-term cardiovascular complication of hypertensive disorders in pregnancy, and management strategies from cardiologist perspective. So, but before I go into the presentation, I want to share this information that according to WHO, World Health Organization, that every 7 minutes, a pregnant woman, at least one pregnant woman, dies from hypertensive disorder in pregnancy-related complications. And we also have to keep at the back of my mind that several studies, and also several studies, meta-analysis, systematic reviews, documented that Africa have the highest burden of hypertension. And among this, among African countries, Nigeria has the highest burden, and some authorities designated Nigeria as the hypertension capital of the world. Also, some experts also designated Nigeria as the stroke capital of the world because of the high burden of hypertension, which is the most common risk factors associated with stroke. So, hypertensive disorder in pregnancy. Hypertensive disorder in pregnancy represent a group of clinical conditions associated with elevated blood pressure, which may predate or occur during pregnancy. The spectrum of these conditions, the spectrum of hypertensive disorder in pregnancy include chronic hypertension in pregnancy, chronic hypertension with superimposed eclampsia, and pregnancy-induced hypertension and pre-eclampsia. These are major causes of maternal and perinatal morbidity, as earlier highlighted by previous speakers. Next slide. It is reported that hypertensive disorders in pregnancy complicate 5 to 10% of pregnancy globally. And hypertensive disorders in pregnancy affect 8.2% of pregnancies globally. But in Nigeria, the prevalence is much higher. than the global prevalence, causing 14% of maternal death, with significant disparities and greater impact on low and middle income countries. In sub-Saharan Africa, hypertensive disorder is the second leading cause of maternal mortality following obstetric hemorrhage. While in Nigeria, hypertensive disorder of pregnancy is the leading cause of maternal death, and followed by pregnancy-related infections and obstetric hemorrhage. Next slide. As earlier highlighted by previous speakers, hypertensive disorder in pregnancy are classified into chronic hypertension, which hypertension preceding pregnancy or developed before 20 weeks of gestation, usually persisting for more than 42 days postpartum, may be primary or secondary, or maybe white coat hypertension or max hypertension. 2, gestational hypertension develop after 20 weeks of gestation and usually resolve within 42 days. And pre-eclampsia, gestational hypertension accompanied by one or more, as earlier, next slide, as earlier highlighted by previous speaker, is characterized by significant proteinuria. It's characterized by significant proteinuria. It's characterized by significant proteinuria, or there may be associated acute kidney injury, or there may be associated liver involvement, or there may be accompanied neurological complication, which includes eclampsia, impaired mental status, and blindness or stroke. Then pre-existing hypertension with superimposed pre-eclampsia is associated with any of the above maternal organ dysfunction, as earlier mentioned, or further rise in BP with new onset of proteinuria. Next slide. And pregnancy is a dynamic process that is associated with significant changes in cardiovascular changes. And these hemodynamic changes include significant increase in cardiac output, which usually occur in all the trimesters of pregnancy, and as well as during labor and early postpartum. Then blood pressure usually falls during pregnancy. And this is observed in the first and second trimester. And then a slight increase is also observed in the third trimester, and during labor and early postpartum, the blood pressure tends to lower. The heart rate is a common, tachycardia is a common findings in pregnancy. In pregnancy, there is modest increase in heart rate, usually observed in the first and second trimester, as well as in the third trimester and during labor. And early postpartum, the heart rate tends to lower. Systemic vascular resistance is observed to fall during pregnancy, during early pregnancy in the first trimester, second trimester, as well as in the third trimester, and usually during labor. Systemic vascular resistance is observed to lower. Next slide. So, hypertensive disorder in pregnancy are associated with significant cardiovascular changes. But although we also have to know that pregnancy, even without elevated blood pressure, is usually accompanied by mild changes in the heart, structural changes in the heart, such as what? Increased thickness of the interventricular septum, and as well as moderate increase, mild increase in the weight of the heart and even size. So this is attributed as a result of what? Physiological changes in pregnancy. And also is usually is contributed by the high cardiac output, and as well as high cardiac output in pregnancy. So other changes that can be observed is left ventricular end diastolic volume also increased during pregnancy, left ventricular end diastolic volume, as well as what? Right ventricular end systolic and diastolic volume. The interventricular septal thickness is observed as well there is slight increase in the interventricular septum, and as well as what left ventricular ejection fraction and longitudinal strength during pregnancy. Left atrial volume was also observed to increase during pregnancy, especially during the second and third trimester of pregnancy. Left atrial contraction velocity was observed is observed to increase during, especially in the third trimester. Then pulmonary venous systolic filling velocity is also increased in pregnancy. So therefore, increase in contractility, left ventricular ejection during left ventricular ejection duration. So these changes provide efficient cardiovascular abduction despite the increase in chamber volume and heart rate during normal pregnancy. Next slide. The long-term cardiovascular implication of hypertensive disorder in pregnancy. Hypertensive disorder in pregnancy is associated with persistent endothelial dysfunction, which is usually observed in patients who have especially those ones with chronic hypertension, can extend beyond childbirth, increase risk of cardiac complication during pregnancy and postpartum period and later in life, increased risk of chronic hypertension within 5 years postpartum, increased risk of acute myocardial infarction, pregnancy-related myocardial infarction, stroke, heart failure, and acute pulmonary edema within 3 years after postpartum. The long-term cardiovascular complication in severe pre-eclampsia or recurrent hypertensive disorder across multiple pregnancies associated with greater risk of premature cardiovascular disease. Hypertensive disorder in pregnancy may be associated with diminished cognitive function months to years after postpartum. The American Heart Association and the American Stroke Association have designated pregnancy-related disorders, hypertensive disorder in pregnancy, as well as female-specific risk factor for cardiovascular disease. Next slide. Left ventricular geometry. Hypertension is a hemodynamic stressor, and it's also hypertension induced significant structural pathological changes in the heart because hypertension is a significant stressor as significant hence subject to hypertension and pregnancy subject the heart to pressure, volume, and volume overload, respectively. Hence, women with hypertensive disorder are susceptible to left ventricular dysfunction as well as abnormal LV geometry. We assess LV geometry and function in our center. We assess 140 women with hypertensive disorder of pregnancy, those ones with chronic hypertension, gestational hypertension, pre-eclampsia, and patient with with chronic hypertension and superimposed pre-eclampsia. And age-matched normotensive pregnant women in Udud, Sokoto. Next slide. And these are our findings. The category of hypertensive disorder of pregnancy that the categories, the chronic hypertension represent 14% of the study population, while preeclampsia represent 32%, and then pregnancy-induced 39%, which is not surprising because most other studies have shown that pregnancy-induced hypertension is the most prevalent among spectrum of hypertensive disorder in pregnancy, and chronic hypertension with superimposed preeclampsia. Next slide. So we observe the LV geometric pattern comparing the normal and spectrum of hypertensive disorder in pregnancy. We observe significant differences in terms of normal geometry is more seen in patients who are normotensive, while concentric remodeling was observed to be much higher in patients with hypertensive disorders of pregnancy. And then concentric remodeling we observe is more in, we observe concentric remodeling to be more prevalent among patients with hypertensive disorder in pregnancy, which we unknown was observed in the normotensive group. Then eccentric hypertrophy was also observed to be more prevalent among patients with hypertensive disorders of pregnancy. Next slide.
Hello, sir. 5 minutes more, sir.
The categorization of left ventricular, geometry among hypertensive disorder in pregnancy with background chronic hypertension and those without chronic hypertension. We observe abnormal LV geometry to be more among those patients that are having chronic hypertension and in those without chronic hypertension. So concentric LV geometry was more prevalent among those with hypertensive disorder with chronic hypertension compared to those without chronic hypertension. Likewise, concentric LV remodeling is also observed to be higher in patients with chronic hypertension than those without chronic hypertension. Eccentric LV hypertrophy was also observed to be much higher among those with chronic hypertension. Similarly, LV diastolic dysfunction was observed to be more prevalent among patients with hypertensive disorder in pregnancy compared to those with compared to normotensive. So, and then the categories of what we observe is that LV diastolic dysfunction was more prevalent in patients with hypertensive disorder in pregnancy. And then indeterminate was observed in 15% of the study population. Next slide. So categorization of LV diastolic function for hypertensive disorder in pregnancy with both background chronic hypertension and without background chronic hypertension. We observe normal LV diastolic function in to be much, we observe higher. We observe normal LV diastolic function in to be much higher in hypertensive in those with hypertensive disorder in pregnancy without background chronic hypertension. And LV diastolic dysfunction was more prevalent among those with chronic hypertension compared to those without chronic hypertension, a group of hypertensive disorder in pregnancy without chronic hypertension. Next slide. And then the grade of LV diastolic dysfunction, we observe among patients with hypertensive disorder in pregnancy, we observe grade 2 LV diastolic dysfunction to be more prevalent compared to grade 1 and grade 3 diastolic dysfunction. Next slide. So the management strategies from cardiologists for early assessment, identifying women at high risk of preeclampsia, early in pregnancy, history of preeclampsia, or woman who is having a history of preeclampsia, multiple gestation, chronic kidney disease, autoimmune disease, and diabetes mellitus. Low dose aspirin for high risk women at 12 to 16 weeks until it should be given to women at high risk at 12 to 16 weeks until 36 weeks. An assessment of end organ damage should be Okay, investigation to assess that should be requested and then be reviewed so that those patients can benefit from okay, lifestyle modification. The regular moderate intensity exercise is advocated in patients who are having hypertensive disorder, among patients with hypertensive disorder in pregnancy, unless contraindicated, 3 to 4 times a week for 30 to 60 minutes. So brisk walking, swimming, and yoga are highly advocated. Weight reduction, especially those women who are obese, weight reduction, appropriate weight reduction is highly recommended for depending on the gestational age. Calcium supplementation, as earlier mentioned by the previous speaker, at least 1 gram per day may be considered to reduce pre-eclampsia risks in women with low calcium intake, less than 600, as earlier mentioned by the previous speaker. Moderate sodium intake is recommended in patients with hypertensive disorder in pregnancy. So moderate intake, not excessive. Mild pre-existing essential hypertension. Assess if patient is having mild pre-existing essential hypertension, assess the need to continue antihypertensive therapy within 16 weeks of gestation. And based on the pregnancy blood pressure, value at initial short-term antihypertensive. For women with office blood pressure less than or equal to less than 130/80 in early first trimester, one can consider discontinuing or de-escalation or step-down therapy in the use of antihypertensive. Well, then you ensure close monitoring of those patients. They should be followed up for up to 16 weeks. Then, if the blood pressure starts rising, then antihypertensive should be instituted, especially if the blood pressure is greater than 140/90 millimeter of mercury at any gestational age. Mild gestational hypertension, initiate therapy if the blood pressure is greater than or equal to 140/90. Pre-eclampsia with severe features, magnesium sulfates, as earlier discussed, highlighted by previous speakers. Hypertension control with labetalol, nepidipine, and alpha-metal-dopa. This group of antihypertensive were found to be very safe and also renal-friendly. Next slide. So in patients with having pre-existing secondary hypertension, preconception counseling is very important, and evaluation of such patient. And the end organs should be evaluated to see if they have pre-existing organ dysfunction, because this has management implication. Women with primary hyperaldosteronism should be discouraged from pregnancy. Eplerenone may be considered as an add-on to other antihypertensive after second trimester is in uncontrolled hypertension. Next slide. Postpartum management. Continue monitoring of BP during postpartum period. Antihypertensive medications are continued or initiated are indicated to achieve good BP control. Antihypertensive compatible with breastfeeding are prepared, like labetalol, nepidipine, metal-dopa, and enalapril. Counseling on lifestyle modification and regular cardiovascular risk assessment is highly recommended. Next slide. So in conclusion, hypertensive disorder in pregnancy are major cause of maternal and perinatal morbidity and mortality with significant long-term cardiovascular implication. These disorders are associated with abnormal left ventricular geometry and diastolic dysfunction. Therefore, routine cardiovascular evaluation is recommended for these women to mitigate the risk of long-term cardiovascular complications such as heart failure, and then structural pathological remodeling, and even electrical remodeling. Thank you so much for this opportunity.
Thank you, sir. We truly appreciate your presentation. We will then call on our chair lady, Professor Hadiza, to take this, to give us her responses.
Thank you very much, Dr. Hayatu, for this presentation. Dr. Hayatu discussed the role of the cardiologist in the management of hypertensive disorders of pregnancy. He discussed the cardiac changes in normal pregnancy. He revised that for us, which is very important. And then also he discussed the long-term cardiovascular complications of hypertensive disorders of pregnancy. He reminded us that there are increased cardiovascular complications both during the pregnancy, in the postpartum period, and some develop later in life in this category of patients. They have increased risks of developing chronic hypertension in their lifetimes, usually within 5 years of developing pregnancy-related hypertension. They have increased risks to developing acute myocardial infarction, stroke, and heart failure within 3 years of developing hypertensive disorders of pregnancy. And therefore, it is very important that these patients are being followed up. Hypertensive disorders of pregnancy and gestational diabetes have also been designated as female-specific cardiovascular risk factors by the American Heart Association and the American Stroke Association. Again, Dr. Hayatu has told us that there are also abnormal geometric patterns among patients with pregnancy with hypertensive disorders of pregnancy. They tend to have higher abnormal LV geometric patterns than normal individuals, and they are also at higher risk of developing left ventricular diastolic dysfunction, which on their own are predictors for cardiovascular disease, morbidity, and mortality. With regard to the management strategy, all the speakers have discussed virtually the same thing, and we understand that early risk assessment is very important in the management. It is very important that these patients present to the antenatal clinics early so that they are detected and patients at high risk of developing pre-eclampsia are picked. Likewise, patients with pre-existing hypertension. There's also need for assessment for end organ damage, including features of kidney disease. And so also, he buttressed on the recommendation for the use of low-dose aspirin in patients that are at high risk. There's also an emphasis laid on lifestyle modification, which is very important and has a very big role in management of hypertension, both related to pregnancy and in patients with chronic hypertension. He further buttressed postpartum care, having known that following delivery, these patients have to be followed up. Blood pressure control is very, very important, as some of the cardiovascular disease may occur after delivery and at a long time. So these patients need to be followed up. And we should be mindful of the use of safe antihypertensive agents in this category of patients. There's a recommendation for use of antihypertensives that are safe for breastfeeding. Thank you so much. I think these are the important highlights. Because of the time factor, we are going to leave all the questions until at the end of the presentation by the fourth speaker. Thank you so much, Dr. Hayatu, for this presentation.
Thank you.
Thank you so much, Chair Lady. We will be inviting very quickly for 20 seconds before we go into the last presentation, we want to invite the president of the Nigerian Hypertension Society just to make a quick remark and acknowledge some of our distinguished members.
Thank you very much, Adora. I just want to take a few seconds to respectfully acknowledge Professor Barstin Omubere. Professor Barstin is the Chairman Board of Trustees of the Nigerian Hypertension Society. He was also a past president of the society. He's well recognized internationally and nationally. He has held previous positions in International Society of Hypertension. Professor Mubere, thanks for all the encouragement. You are welcome, sir. Thank you.
Thank you, sir. So we will delve into the last, but definitely not the least, for today. Please let us welcome Dr. Loretta Michelia for her session. Take it away, ma.
Okay. Good evening, everyone. And standing on existing protocols, I would like to add to that I would like to thank the organizers for giving me the opportunity to be part of 2025 webinar pertaining the Nigerian Hypertension Society Day. I'll be taking the neonatal aspect of this presentation. We'll be looking at the fetal outcomes, the neonatal complications, and long-term effects on the child. Next slide. So the learning points of this particular presentation will be to recognize the burden of morbidities in the newborn as a result of being delivered to mothers with hypertensive disorders. Also to understand the implications of the hypertensive disorders in the mothers on the fetus and the newborn, and to know why the reasons these complications occur, and to also have an understanding of both the early and late consequences that are seen in these newborns. Next slide. Next slide. Okay, so hypertensive disorders of pregnancy has been emphasized and re-emphasized that it's a significant contributor to both fetal and neonatal mortality in Nigeria. And the fetal maternal outcomes of hypertensive disorders of pregnancy are affected by multiple factors. And this includes the gestational age at the onset of the hypertension, the presence of multifetal gestations, and comorbid conditions in the mother, like diabetes mellitus, cardiac pathologies, and background renal diseases. Now, all this affects perinatal health negatively, as a study has shown that an estimated 500,000 babies die each year from mothers that have pre-eclampsia or eclampsia alone. And you would all agree with me that this is such a huge number. Next slide. So these hypertensive disorders are linked to increased risks of adverse outcomes in the babies. And these include preterm deliveries, babies come out and they're low birth weight. Then we could have babies with intrauterine growth restriction, and unfortunately, some are stillbirth. Now, what's the implication of all this? It leads to increased NICU admissions, prolonged hospital stays, added financial and psychosocial strain on the families, of which most times they are really ill-prepared for it. And in the long run, the society also suffers from this, in that there is reduced productivity because the labor force has gone down. Therefore, early detection and management is crucial for improving fetal outcomes, particularly in our country, Nigeria. Next slide. Okay, so let's look at the burden based on few studies that have been done over the country, around the country. In 2008 in Port Harcourt, some of the complications seen in such mothers were that they had babies that were preterm, low birth weight, severe birth asphyxia, sepsis, and perinatal deaths. And we all know that right now, the neonatal mortality rate in Nigeria has gone up. So these mortalities or morbidities also add to the neonatal mortality rate. Then a more recent study in 2020, this time around done in southeast of Nigeria, documented that preterm births accounted for 56.6% of mothers with hypertensive disorders, and 16.2% resulted in perinatal deaths. North Central Nigeria, and to be particular here in Abuja, a study that was done in 2021 found that stillbirth rates accounted for 10.7% of the babies, and majority of them were low birth weights. They were less than 2,500 grams. And then just last year, there was a systematic and meta-analysis study done and it also showed a high mortality rate of 16.73 in those whose mothers had hypertensive disorders. Now, they might just look like numbers, but unfortunately, they do translate into a huge burden on the newborns. Complications do occur in these newborns that are delivered to mothers that are hypertensive, and they could either be early or later in life. And the hazards of these outcomes actually depends on the severity, the type of hypertension that the mothers have. Is it an eclamptic issue or is it pre-eclampsia? The gestational age at the onset of the hypertension, the gestational age at the time of delivery, and then the availability of quality or specialized available care, which we all know that it's a bit difficult, especially those that are in primary health or secondary health facilities, and even some of the tertiary facilities. Not every facility is fully equipped to handle specialized newborn care. Now, majority of the fetal complications arise as a result of spasms and vascular dysfunction. This has already been emphasized in the previous lectures. And this leads to a dysfunction of the uteroplacental circulation, which eventually leads to hypoxia, fetal distress, preterm delivery, and ultimately deaths of the newborn. Now, these complications, they occur. We have early and we have late. So as part of the complications that occur, it's not particularly on this slide, but we do have medications that are used in the mothers during antepartum or the intrapartum period. And effects of giving the mother magnesium sulfate can lead to hypermagnesemia in the babies, and they end up having hypotonia and respiratory depression. Then other antihypertensives that are given to the mothers, especially calcium channel blockers, may cause hypotension in these babies. In addition, we've been told already that a definitive treatment in mothers with hypertensive disorders is to deliver the baby. Now, depending on the gestational age of the baby, they may come out premature. And when these babies come out prematurely, we all know the impact. They end up having complications like respiratory distress syndrome, infections, intraventricular hemorrhage, and feeding difficulties. Then they also have fetal growth restriction, and all this mainly is due to vascular dysfunction. And this results in slow growth, and then the babies end up having low birth weights. Now, when the vascular dysfunction continues and it gets prolonged, it may lead to risk of placental abruption, and then ultimately fetal death. Next slide. Necrotizing enterocolitis is also another complication that we see in these babies. And this occurs as a result of alteration of the intestinal microbiota, which can in turn be associated with different events that leads to NEC. Neonatal nephrogenesis occurs mainly in the 3rd trimester of pregnancy. So any baby that comes out before the 3rd trimester could adversely be affected, as in the fetal kidneys are not fully developed and then renal dysfunction is present. Next slide. Okay, so for the late complications, these occur much later in life. And basically, it's as a result of fetal adaptations to an adverse intrauterine environment. And this happens, then they now have a developmental programming. And when that happens, it increases the risk of morbidities. So what are these morbidities that could occur? Now, they could have nutrient insufficiency, and with the nutrient insufficiency, they tend to have a phenomenon known as thrifty phenotype. Now, with the thrifty phenotype, what happens is that because the fetus is not well malnourished, they tend to have something called a catch-up growth. And when they tend to have the catch-up growth, they may end up with complications like obesity in later life. Now, other sequelae that arises as a result of the developmental programming includes neurological disorders, cardiovascular issues in future, which could be things like myocardial infarction, and they could also have hypertensive heart diseases. Then they could also have cardiometabolic dysfunction. Next slide. Other complications later in life include cognitive impairment. They tend to have delayed physical development and sensory motor reflex maturation, increased body mass, changes in neuroanatomy, and hormonal changes. Next slide. Okay, so just to drive home the point, I thought I should put up a pictorial representation of what I have been saying. Now you can see the baby on the right side, the one that is premature, and we can all see the different gadgets that are on the baby just to help the baby to breathe, to stay without infections, and to give the baby a chance at life. Now, this picture depicts a hospital that probably has a very high-functioning NICU, and they have all the equipment, which is not what is available a lot. Well, it is available in some places here in our country, but we pay a high cost for neonatal and newborn care. Now, the picture in the middle, unfortunately, is showing us a stillbirth baby. Baby didn't make it, and we all know that grief is a very real and raw emotion that parents, especially a mother, having carried a baby for some months and then losing the baby, it actually takes a toll on the mother and the family. So for the last picture, we can see two babies. One is growth restricted, and growth restricted babies, that's the smaller baby, of course. Growth restricted babies come with their own share of problems, which leads to admissions, hospital stay, and it becomes a burden financially and socially and psychologically on the family. Next slide. Next slide. Okay, so this is just a summary of the neonatal complications, and we've already said them. And really, when it comes to management, it depends on what the child or the newborn is presenting with. So you manage accordingly. Next slide. So in conclusion, pregnancies complicated with hypertension are associated with adverse fetal and neonatal outcomes. We cannot overemphasize this fact. And some of the complications are intrauterine growth restriction, prematurity. They end up having low APGAR scores. We end up recording early neonatal deaths, high rates of admissions into the NICU, and the need for resuscitation. So expectant management with temporizing treatment should be performed to lengthen the gestation, which may be associated with enhanced perinatal survival, because we all know that the babies of today become the adults of tomorrow. So good intensive care, close monitoring during labor, judicious timing of delivery, and NICU facilities are required for fetal and neonatal outcomes. Thank you very much. These are my references, and thank you for your attention.
Thank you so much. And thank you for keeping to the time as well. I think it was very, very intentional by the executives to have left this for last. I think it just talks at the heart of the different folks on the call, and pretty much a call to action to make sure that even as we engage with our patients, we're intentional about taking care of both the mother and the effects of hypertension on the fetus and the baby. Thank you so much, Ma. We will then give room to our chairpersons to also respond. And then we will go into a very brief discussion. But I would also like to invite the Secretary of the Nigerian Hypertension Society, Dr. Fason, to also speak. So we'll take a remark and recommendations from the chairperson, and then we'll hand over to Dr. Fason. Thank you so much.
Thank you so much, the moderator. Thank you, Dr. Loretta, our pediatrician on board. Thank you so much. I think she has really given us the perspective of the pediatrician and neonatologist on the impact of hypertensive disorders of pregnancy on the fetus, newborns, and the long-term consequences on the child, even after growing up to adulthood. What are the risks associated with it? I think this is actually very educating. She also mentioned about the burden on this and told us about that hypertensive disorders of pregnancies are associated with high perinatal morbidity and mortalities, especially in our setting. And she told us about some of the complications that the newborns can suffer, which include prematurity. The newborn can be delivered premature, especially either iatrogenically or even when they fall into labor, and also low birth weight. Also, even before delivery, the fetus can actually have intrauterine growth restriction, or sometimes the suffer demise, what's called intrauterine fetal death, even before delivery. And that would be a great loss, even to the mother, to the family, and even to the managing team. Sometimes the baby are also delivered as stillbirth, as have rightly been mentioned. Then there are a lot of issues also on the facilities in which these babies are actually posed to. They tend to have a prolonged hospital stay. Then also you need to actually provide neonatal intensive care unit for the NICU for them. So an hospital that does not have this, might not be able to really manage both the baby and the mother effectively. Then if you look at the resources, is actually a strain on the financial and the material resources available in this facility. So all those things have already been mentioned. Then talk about what are the things that determines what the eventual outcomes of these babies are going to be. It depends on how severe the hypertensive disorder of pregnancy is. It depends on the type. We say that people tend to actually have a good fetal and maternal outcome with maybe PIH, pregnancy-induced hypertension, or gestational hypertension. But when it comes to pre-eclampsia and severe eclampsia, or chronic hypertension with superimposed eclampsia, the outcome is really very, very bad when it is not being well managed. Then the onset of these disorders at gestational age at which the disorder is taking place, the ones that have an early onset tend to have a more adverse outcome on both the mother and the fetus compared to the one that have a late onset. So she told us about that. Then the gestational age at delivery. Sometimes the obstetrician might not have a choice than to actually terminate the pregnancy, especially when there are severe symptoms. So because of that, it will also affect the outcome of the baby. Then other comorbidities and also available facilities will determine how the baby is going to really pull through. We mentioned that those are the actual things and there are a lot of lessons to be learned from this presentation, which we need to really take home, that we need to actually have all things on ground if we really want to reduce the burden and the complications. We need to really have the neonatal facilities well equipped. We need to have an intensive care unit. We need to have appropriate drugs available. Then even at our primary health facilities, we need to have things that they can actually help them to really screen this patient. So thank you so much. I think this has actually been a very educating webinar. And I think we can go to the general discussion, which because of our time, we might not be able to take really so much, but the moderator, I think, how many questions are we allowed to take now because of our time?
Yeah, so what we'll do is we'll have Dr. Fason talk. He has a brief discussion around the society. Then we'll do the post quiz, and then we'll take the questions and discussion. So far, we've compiled a number of the questions. Some have been answered, so we'll just eliminate those that haven't been answered, and then we can manage within the time as much as we can take within the 15 minutes will be great. Thank you so much, sir. So over to you, Dr. Fason.
Yeah, Adora, thank you. I hope I'm clear. I hope I'm clear enough.
Yes, sir. Yes, sir.
Okay, it's raining heavily here in Abuja. We'll say a big thank you to MDoc for hosting this program with us, and also to our speakers who have shown as specialists in the areas of the subject that we are discussing. they've shown, they've brought in a lot of their experience and of course the knowledge they've garnered over the years. It's been a fantastic program so far. We thank all the attendees, and just to say that, and of course the ESCO of the Nigerian Hypertension Society. I'm Oladipo Faso, I'm the Secretary General. And I just want to say that the Nigerian Hypertension Society is an umbrella body of all specialists, doctors, and allied who are involved in the management of hypertension in Nigeria. We are dedicated to prevention, diagnosis, and treatment, as well as the control of hypertension in Nigeria. This program is being organized as part of the World Hypertension Day commemoration. The World Hypertension Day, as we all know, will be coming up on the 17th of this month. That's Saturday, and this program was organized to commemorate it. In addition, the Nigerian Hypertension Society is organizing programs all over Nigeria, and so I'm encouraging all our attendees to please key into the program. We have representatives in every state in Nigeria, and they already have joined up programs for the World Hypertension Day. Along the line, we also have the May Measurement Month called MMM, which starts from 1st of May and ends by the end of July, July 31st. It's a period that we go around
Sorry, I don't know if it's from my end. Can anyone hear me?
Yes, we can hear you, Adora.
Okay, so I think it's from Dr. Fason's end. He says it's
I think it's from his end.
The weather,
Nigeria, and we measure
Nigeria. Oh,
blood
okay.
pressure of auditing awareness, which is. Can you hear me now?
Yes, we can hear you now. Maybe you have to turn off your video, Dr. Fason, so that it will.
Can you hear me now?
Yes.
Okay. As I was saying, I don't know where I got stuck, but we have a website. It's called tnhs.org.ng. We encourage everyone to visit. And of course, we encourage everyone to take up membership with the Nigerian Hypertension Society. This is a burgeoning society that we should all be part of, and of course, take to greater heights. So that said, before we go into the sessions, I will maybe I should hold on. I have a few things that I want the speakers to highlight.
Yes.
Maybe I'll ask them now. They can discuss them.
Okay, so we will take the post quiz and then we'll come back to yours. We'll start off with yours.
After the chairpersons have spoken.
Yes, sir.
Okay. Fantastic.
So we'll be launching.
Do I hold on or do I go ahead?
Please hold on,
okay,
sir.
Okay, good.
Yeah.
Okay, fantastic.
Okay, so we're launching the post quiz now. Remember, I mentioned that prior to the didactic, everyone will have an opportunity to respond to the questions again, now that we've had conversations. Please. Please, if you're a co-host, do not move around on your screen so that you don't abruptly end the poll. Everyone is encouraged to please take the quiz. Again, there's no penalty. It's all for us to learn. We're still going to take a couple of questions and a discussion. So please feel free to answer the questions. We have just 5 minutes so that we can complete this. We want as many people as possible, as we would want to show that this was a very educative session and calculate the amount of the percentage knowledge gained. So I'd encourage everyone to please read through the questions and answer accordingly. Thank you. Thank you. I see some answers coming in. Well done, everyone who has submitted. I'd encourage others to please take the polls. If you're a co-host, please do not move around on your screen. Thank you. Please don't overthink it. Just read it. Pick the we've gone through a series of sessions. From what we've learned, let's pick the most accurate answer. Read your questions carefully so that you make sure you're taking the right answer. Thank you. I see some answers coming in. We do need more people responding. And if you did not take the pre-quiz, that's okay. Please attempt the post-quiz. The goal is to make sure that we are learning. And that's the most important thing. We have 2 more minutes. Please feel free to attempt the questions. If you can't see it on your screen, please go to where you have chats. You would see polls/quizzes. If you click on it, it will launch the poll for you. If you're using a phone, you'd see the 3 dots where you normally have chats. Click on that, you see polls/quizzes. It will pop up on your screen. We do need more people to take the polls. I see some answers coming in. So closing shortly so that we can delve into the discussions and we can end the session. 1 more minute before we close the polls. Thank you to everyone who has submitted. I want you to, if you've started, please hurry up and submit. If you haven't started, you have 1 minute to do so. There are just 8 questions, so please go ahead. Thank you. So we're closing the poll in 30 seconds. Please feel free to fill out if you haven't, so that we can close the poll and go into the conversations before we end this particular webinar. Okay, we're closing the poll in 20 seconds. Please feel free to complete it so that we can close. Okay, yes, you have 10 more seconds. Someone just messaged me. You have 10 more seconds to send in your responses. Okay, I will have to start the countdown. 10, 9, 8, 7, 6. I'm just taking my time for that last person that is going to submit. 5, 4, 3, 2, and we will be closing the polls now. Thank you to everyone who submitted. Thank you. So we'll go very quickly into the conversation with Dr. Fashion starting off. Please go ahead, sir.
Okay, thank you once again, Adora. And again, thank you to all our speakers. You guys have been wonderful. We just have a few areas that we think might need more clarification, and then, of course, more questions will come. First, maybe I should pose this to Dr. Garba, or maybe any of you, maybe, because in all the presentations, I didn't hear where we talked about the blood pressure target these patients. I know we use magnesium sulfate to prevent the convulsions that come with it, and we use antihypertensives, yes, but what's our target? Do we set the same target as the general patient, non-pregnant women or man, considering that the new guidelines, for instance, European Society of Cardiology and ESH, say that we should aim towards 120, 129 systole. Is it the same in this condition? That is one. Anybody can answer that. The second part is specifically for the nephrologist, Professor Adejuma. Looking at serum creatinine as a marker of renal impairment in pregnancy and looking at renal complications of pregnancy in these hypertensive disorders of pregnancy. Can you elucidate, can you tell us a little more? How reliable is it really? Are there issues in pregnancy that could affect serum creatinine, eGFR? And I think, Dr. Garba, I will put this to you. Considering I looked at the epidemiology you gave us, of course, is gory. And we also know that in this part of the world, a lot of our patients visit traditional homes, traditional birth attendants. And in the face of the current Ministry of Health concept of task shifting, task sharing in management of hypertension, what do you think about, what do you think we can do differently regarding traditional birth attendants? Maybe, can they be partners in this process in trying to help reduce the prevalence and the severity and the complications and the mortality and morbidity that comes with hypertension and pregnancy? Yeah, I think I wanted to ask a few more, but I think I should leave it at that so that we can go straight into the question and answer sessions. Thank you.
Okay, thank you very much, sir. I think let me respond to the first one, the target blood pressure control. As we have stated in the, okay, I think the nephrologist talked about wanting to start antihypertensive 140/90 or at 140/90. Actually, in pregnancy, the target blood pressure control when we are using antihypertensive, for us to say we have achieved good control, is we should have a systole of at least 130 and diastole of less than 85. So we wouldn't want to crash the BP too low, unlike those that are not pregnant, because it may affect the placental perfusion and may subsequently have impact on the baby. So probably that may be the reason why the cutoff or target blood control is set at least 130/85, the diastole. So these are what I have regarding the target BP control. Then regarding the traditional birth attendants in the management of hypertensive disorders and pregnancy, I think if we are talking of skilled birth attendants, they are not skilled birth attendants. So we shouldn't consider them as people that will help us in their management, because they don't have the skills to identify those antihypertensives, they don't have the skill to administer magnesium sulfate. I think the task ahead of what I think we should aim at is educating them about the danger signs of
Can anyone hear me?
Yes, please.
We can hear you. I think it's from our end.
Okay, it's from her end. Okay.
Well, any of the speakers can come in meanwhile.
So please, can we Team, can you allow Professor Oluseyi to jump in, please? Can we make sure that he's able to unmute himself?
All right. Thank you, sir. Dr. Faso was asking about reliability of serum creatinine and GFR. And I mentioned in my presentation that there are some changes that occur, physiological changes in pregnancy. One of them is there's hyperfiltration. With hyperfiltration, the creatinine drops. So the serum creatinine drops. So it's very difficult it won't be proper to exclusively rely on reference value of serum creatinine, because of course when we are talking about acute kidney injury, you are talking about percentage rise. A percentage rise, you are talking about doubling values. So if you take into consideration the value, absolute creatinine value, consider how you say it is within reference value, that may not be completely true. But if you have a baseline creatinine, then you can do a serial monitoring, that you can start talking about increase, between 5% increase, 30% increase, even though the value of the serum creatinine is still within the reference value. So we should take that into consideration because of the pregnancy effect. In terms of course, GFR has its own limitations, especially in pregnancy. I talked about hyperfiltration, which will take the GFR up. So if you have a slight decrease in the value of GFR, even because of hyperfiltration, you can still have GFR within normal limits, and that does not exclude an acute kidney injury. So, but there are other reliable markers like NGAL, but the challenge with NGAL is that for now, we cannot use it routinely in monitoring renal function because of the costs. So we still use our serum creatinine, use the GFR, and also consider this proteinuria, even dipstick urine analysis for proteinuria or albumin creatinine ratio or PCR. But of course, NGAL has been found to be more superior in monitoring renal function in pregnancy. Thank you, sir.
Thank you so much. I think we have responded.
Okay. Welcome back, ma'am. Dr. Fashion,
Okay,
can you hear us? No problem at all, ma. We understand.
Yes, yeah, good.
Okay. So we'll hand over to the chairpersons to take a few of the questions. We may not be able to take all, but they will take a few of the questions and then we can wrap up. Thank you. Thank you for all those who have stayed this long. We're almost at the finish line and we can call 2025 our 2025 webinar a wrap. Okay, over to you, chairpersons.
Thank you so much, the moderator. I think we'll just quickly go through some of the questions, the one we can answer, and the other ones can be directed to the speakers. So I think I would like Dr. Garba to answer this. How can religious and cultural barrier be addressed to encourage women to attend regular antenatal care? I think that's very key in our setting. And it has religious and cultural factor have been an issue. And you see so many of our women booking in the mission home. And in this mission home, blood pressures are not taken. They don't even do urinalysis and all those things. And some other issues that are also associated with the cultural barrier in allowing women to go out and being attended to, even by men or male healthcare workers, all those things. So Dr. Garba, maybe you can just take that.
Okay. Thank you very much. I think is one of the major issues, one of the major challenges. Yes, sir. I'm speaking.
Go ahead.
Okay, sir. I think this issue of cultural and religious barriers are one of the major challenges that we have in our environment. Still, there are programs that have been ongoing, but we still need to do more. Most important, I think, is that advocacy to the religious leaders, to the village heads. Once they have understood, because they feel they listen to them more than we in the Western education, they feel that every tool we bring might be harmful. But if we're able to go into at community level, educate the religious leaders, the village heads, the family heads, not necessarily the husbands, to understand the impact and then the need for them. So I think we can break those barriers. So efforts have been made, and I think if we continue that, we can be helpful. We can get more improvement. Then poverty, because healthcare is not free. So even coming to the hospital might be a problem. Access roads, delay in transport, all those things are part of those that think. And they believe that eclampsia, they believe that it's spiritual. They believe that they will say, in our language, they will call it iskade. So they feel they have their spiritual things, not really the hypertension. So we have to make them understand that it's really something that we can do in the hospital, we can manage, so that they will understand better. So this is what I have regarding the cultural and social, religious and cultural factors that are hampering the effect of pre-eclampsia in our environment, sir.
Yeah, thank you so much. I think in addition to that, the head of our religious bodies should be carried along. I think the advocacy, also the awareness, should also be taken to the religious body, to the religious gathering about some of the symptoms of this. They should then, in as much that we cannot eliminate the place of religions and some of this cultural belief, some of them, because of our nature, we believe, yeah, there is also religious backing to most of those things. So even when you tell them to go and book in a PAC or book in a health facility, they believe they have to go and pray in the mission home and all those things. So I think the emphasis should also be laid that attending a mission home does not exclude them from attending a health facility. They must be registered, they must book, and they have different roles. So while they can gather and pray and jump around and sing together and exercise and everything in a mission home, they need to see a healthcare provider who will do a skilled birth attendant who will provide facilities. So thank you so much, Dr. Garba. Then the other question that have been raised is that some have been answered. What is the first drug to be given? We said, Professor Adikuma said nifedipine, and especially in the primary health facility, that should be readily available. Pre-eclampsia without elevated blood pressure. Yes, can we have? Yes, there's what we call atypical pre-eclampsia. I think that answered that, so which would not actually meet the criteria that is really being defined for the general definition of pre-eclampsia based on the gestational age, based on the existence of elevated blood pressure, or sometimes proteinuria. So I think that answered that. Also, can we have pre-eclampsia without elevated blood pressure, without proteinuria? Sorry, I'm reading those. Can you have pre-eclampsia with elevated blood pressure only without proteinuria? Yes, we can have that. That come in to play with atypical pre-eclampsia, but we should know that there are also spectrum. You understand? Well, that can actually be defined as PIH. Do you understand? It can also be a gestational hypertension based on at what gestational age you are picking it. For a facility that have no doctor, what is the best to give before referral in a woman? That one has also been answered, that you can actually give a nifedipine. In remote area where magnesium sulfate is not available, what is the substitute and precautions? I think maybe let me call Dr. Galba to answer that. What are the substitutes for magnesium sulfate in case magnesium sulfate is exhausted and the woman is convulsing? What can we give, Dr. Garba?
Okay, thank you very much, sir. Sir, before now the only recommended gold standard is magnesium sulfate. So there's no recommendation on any second line. However, before we were used to magnesium sulfate, there were a lot of combinations, the light cocktail, where we give a combination of the diazepam, Venobarb. They have been used, but recently, actually, it's only magnesium sulfate that has been recommended. But instead of allowing, supposing they are in a rural center, instead of allowing the woman to be convulsing, I think we can still go back to our former, what we were using before we got the diazepam, before we got the magnesium sulfate. So probably we can give diazepam if it's available, because I think it's one of the commonest sedative that we can have. But it's only magnesium sulfate that is the recommended one for now, sir. I
Yeah,
don't know
thank
if
you
you
so
have
much. You're right. It's magnesium sulfate that is recommended, and it's not only as a seizure prophylaxis, it also has some neuroprotection for even the neonates. So this is very important even for the neonatologist. It has confirmed some evidence base. It shows that magnesium sulfate. But we all know that in our rural area, sometimes some of these things get exhausted. Sometimes they are expired on them. And so what do the alternatives? And the alternatives have been mentioned by Dr. Garba. Diazepam, yes, it can be used. And sometimes you even use magnesium sulfate. I've had like 2 or 3 patients manage that even with repeated magnesium sulfate giving, the convulsion still continues. So we had to resort to diazepam to give to the woman, so especially after delivery of the baby. So sometimes there's a role for that. And we also have some other ones like phenytoin that can also be given. So thank you so much. Then looking at the other questions, is there an alternative? We've answered that. Is there alternative to magnesium sulfate? We mentioned that diazepam, phenytoin, then some of the cocktail. How about proteinuria in pregnancy in the absence of hypertension? Yes, you can have proteinuria in pregnancy. It's for, number one, it can be atypical pre-eclampsia. 2, it can be that there's an underlying kidney disease. You understand? Or there are other things that we know that can actually cause proteinuria. Then it depends on the level of proteinuria that we're talking about. Sometimes it might be just a contaminant, because pregnancies sometimes in intrapartum, bleeding, low care, some of these things contain protein. So it might be a contaminant. So you have to be sure of what you are doing. Is it really significant? Then you need to really rule out other kidney disease that might actually be associated, which is actually also a risk factor for this hypertensive disorders of pregnancy. What does it mean and how do we manage it? So I've mentioned that you need to evaluate further to really know how significant the proteinuria is. Have you ruled out other things, other conditions that can lead to proteinuria? In patients with estimated gestational age of less than 34 weeks with severe symptoms, what do we do? Yeah, less than 34 weeks, that's this patient should, after stabilizing, should be referred to where you have a neonatal facility, knowing fully well that when this baby is delivered, the patient will need a neonatologist and everything. So this patient should be, after stabilizing, given the startum dose, I think should be referred. I don't know if the neonatologist, Dr. Loretta, do you have anything to say to this?
Good evening. Good evening, sir.
Yeah, good evening.
Okay, so sorry, we've been talking a lot about the mothers and the mothers and the mothers. Sorry, so could I hear the comment again?
In patients with estimated gestational age of less than 34 weeks with severe symptoms, what do we do?
Oh, wow. Okay, so I can only talk about it from the neonatal point of view. Now, gestational age has an impact on the outcome, positive outcome. So the more preterm the baby is, the higher the possibilities of more morbidities are in the patients. And then, of course, they tend to have a higher poorer outcome. So for babies that are 34 weeks and less, if the obstetricians can give good monitoring of the mother and are able to prolong the gestation, not at the expense of the baby. That would be an excellent thing to do. However, if the baby has to be delivered, then it is best that mother and baby are both referred together. That is, baby should be in utero and then referred to a facility that has good NICU services. Yes, sir.
Thank you very much. I actually
Excuse me,
want
sir.
that emphasis on that because some of our healthcare providers, they will deliver the baby and where the neonatal facility is not available, forgetting that they are dealing with two lives and they will now start referring the baby to a place. I think that should be noted. This woman, if at all, should be referred where the both lives can actually be managed. Dr. Garba, yes, you have the floor.
Okay, thank you very much, sir. I just have an addition. One, as throughout our lecture, we said we shouldn't compromise the life of the mother. If you can get both, fine. But our priority should be to the mother. So if once we have made the diagnosis of pre-eclampsia with severe symptoms less than 34 weeks, so as much as possible, that woman should be stabilized and to be delivered within 24 to 48 hours. So during that 24 to 48 hours is an ample time we give magnesium sulfate, which is neuroprotective for the fetus. We also give dexamethasone. I think those are the things that we can start doing within those 24 to 48 hours that we have made the diagnosis of pre-eclampsia with severe symptoms, and then refer, as the neonatologist have said, we should refer to the center that have a good neonatal intensive care unit so that both the mother and the fetus can be managed and we have good outcome. Thank you very much.
Yeah, thank you so much for that. Yeah, it is postulated that preeclampsia has two phenotypes, which require different treatment strategy. What is your view? Some people have noted that women carrying female fetus with preeclampsia with severe features do well on magnesium sulfate than women who carry male fetus. What is the likely basis? Well, we all know that usually not only for preeclampsia, even for some other obstetrics emergencies, obstructed labor, and some other condition, antepartum hemorrhage, female fetus delivered tends to do well, even as preterm, more than the male fetus. So the basis of that, maybe I will call on is not due to magnesium sulfate. Magnesium sulfate does not have a specific differential effect on the sex of the baby. I think it has to do with the survival of those fetus, either based on their sex, male or female. So, but I want the neonatologist to speak on this. Dr. Loretta.
Maybe she's
Hello?
not.
Okay.
I don't think maybe her network has bumped her off.
Okay.
So we can go to the next.
Okay, let me go to the next question. Okay. Please, is it in all type of preeclampsia or eclampsia that brings about termination? No, we've said that there's spectrum of hypertensive disorders of pregnancy, and when it comes to classification, even preeclampsia as type, you have preeclampsia with severe symptoms, preeclampsia with mild symptoms. The one with mild symptoms can be managed conservatively if biochemical parameters and clinical parameters still allows you to continue. And there are things that we need to monitor, intrapartum monitoring, which has been highlighted in the presentation given by Dr. Garba. I think that has been answered. And at what age of gestational age can be pregnancy? That there's no cut. You understand? All we want to get to the age of long maturity. By the time you get to age of long maturity, severe preeclampsia with severe symptoms can be actually term. However, if it is mild, you can still allow to go to term, because the more the pregnancy advances, the better the survival of the fetus. So, but there's a delicate balance that you need to maintain on when to deliver this your mothers in order to ensure the safety of the mother and also of the babies. So you must actually balance that. How does assisted reproductive technique lead to preeclampsia? Yes, it is from our knowledge of immunology. We know that immunology is one of the theory that actually has been proposed to lead to preeclampsia because the fetus is being regarded as a foreign body. So most of the assisted reproductive technique sometimes make use of the donated gametes from the male partner or from the we have donor eggs also can be used. So this can actually be a risk factor. That is why. Can the pregnancy be allowed to continue if fetal-maternal status improve following magnesium sulfate administration? Yes, it can be allowed to, but should be terminated at 37 completed weeks. It shouldn't actually go further. Yes, but care needs to be taken because we must be sure of what we are evaluating. Our biochemical parameters must be improving, but the theory actually says that it's a progressive disease. And usually, when you look at it, I've not seen an improved, but it can remain static, but doesn't really improve from my experience. But I don't know, maybe some of our other speakers can talk about those. I've never seen one that's okay, now have hemolysis, elevated liver enzyme, and the liver enzyme now goes back until the baby is being delivered. Dr. Garba, I don't know if you can speak to those.
Sorry, sir, I was, can I hear the reason again, sir?
He said, can the pregnancy be allowed to continue if fetal-maternal status improve following magnesium sulfate administration?
Okay, yes, sir, the recommendation, if we are following the standard recommendation, is that once we have made the diagnosis that this pre-eclampsia is with severe symptoms that warrant giving magnesium sulfate, that means we should aim at delivery between 24 to 48 hours, regardless of the gestational age. It's not recommended that we give the magnesium sulfate and allow the pregnancy to continue. However, in our environment, when we have pre-eclampsia at 30 weeks, 31 weeks, and we feel our intensive care units may not be able to nurse or cater and give good or give outcome, sometimes we tend to put some emotional concern and continue monitoring, be watchful, and then try to conserve and see if we can reach that 4 weeks. But the standard recommendation, we should terminate that pregnancy for the sake of the mother.
Thank you so much. Thank you. I think we have only 2 questions left, which I will quickly answer before I hand over to the moderator. Is hydralazine injection indicated during pregnancy? Yeah, we've said that the first line of antihypertensive, nifedipine, labetalol. But sometimes I've seen instances, if labetalol is not available, you can give hydralazine. Then sometimes labetalol is not working, we can also switch to hydralazine, but it's not part of the first line of treatment as recommended by. But I've seen patients too that we give after giving labetalol is not working, need to resort to hydralazine. But we have some other first line of drugs that can be used. Patient that is not taken orally, that you can't give nifedipine, you can't give Idomate, and labetalol is not working, you might need to resort to hydralazine. What are the intrapartum preventive measures that should be taken when delivering a mother with pregnancy? Yes, those have been outlined, which include that we should give what intrapartum preventive measures. You need to do intrapartum fetal surveillance. Surveillance needs to be done, and this include some of those things that be recommended, even as simple as fetal kick charts, the Doppler ultrasound. You can also use a sonicate to also measure adequately. Then also, you can also, the use of magnesium sulfate to, as I've said earlier, also helps in is neuroprotection for the baby, and it might also improve then giving of corticosteroid. They are very important in also to ensure long maturity, and they might also help to improve the fetal outcome. I think those are the questions that have been raised. I don't know if there are any other. At this point, I will hand over to the moderator if there's any other or any of our speakers want to speak.
Yes, thank you so much, sir. Thank you, Mr. Chairman. We do have a quick comment from Professor Larenwaju. If we can please give Professor Larenwaju the ability to unmute himself and make his contributions quickly before we wrap up. Hello, Prof. Can you hear us? Do we still have Professor Larenwaju on the call? Yes, please go ahead, sir. Can you hear us? Yes, please go ahead.
All right, thank you very much. I really appreciate the speakers. It has been very, very wonderful talk. And I appreciate especially Professor Adejuma and my colleagues that have spoken in the side of nephrology aspect. I would just want to make quick comment because there is an issue, a current issue going on really in nephrology that has extended into the determination of kidney function for diagnosis of kidney disease in hypertension in pregnancy. Creatinine, which has been conventionally used, has now been debated strongly and is gradually to be displaced by other biomarkers. It has been shown very clearly from all the studies both in West here that creatinine underestimates GFR in plaques. And like Professor Adejuma said, that is very true even in pre-eclampsia where there is hyperfiltration. When you have hyperfiltration, the serum creatinine is reduced and therefore it's going to give, a falsely underrepresented or underestimation of GFR. What has been found consistently and with a lot of study going on now, in fact, 2 of them were published, a very strong paper in 2021 now, where they compare serum creatinine with other markers like uric acid, like cystatin-C. It has been shown very clearly that the sensitivity and specificity of serum cystatin-C is far, far better than other markers, especially serum creatinine. Indeed, in all the population study as well, and also in Nigeria, we have not utilized that cystatin-C. And the global study has shown that when you incorporate it with creatinine, when you combine cystatin-C with creatinine, it gives better representation of the GFR. And if you use cystatin alone, it is better. Although it is not currently being used, but the study is pointing towards that, and everybody is advocating for that. That is the way to go. So in the short time, people may have to migrate from using serum creatinine as a measure of the kidney function, not only in general population or in patients suspected to have kidney function, but even in pre-eclampsia, because it shows that it detects even pre-eclampsia very early, and it also detects kidney disease in the general population early, just because it's not affected by muscle mass, by age of the patient, and by the diet. And all these affect serum creatinine. Creatinine responds to the age of the patient, to the diet, especially the protein that the patient takes, and of course, to the muscle mass. Thank you very much.
Thank you so much, sir. Thank you. Thank you. Thank you. So we would move very quickly. Remember, just remind us that we are offering continuous professional development points for this particular session. If you are interested and you're a doctor who has been part of this session, has stayed for a substantial amount of time and has been part of the discussions, please feel free to send us an email. We've put the details in the chat with your full name, your folio number, qualifications. There is a fee, a processing fee of 3,500 Naira, and we'll be looking forward to hearing from you for as many as are interested. We would very quickly go to our vote of thanks. I will be handing off to the president of the Nigerian Hypertension Society to please give his vote of thanks or nominate who he would like to give the vote of thanks.
If I may come in, we've had, I think, Dr. Manven.
Sorry, can you say that
Dr.
again, sir?
Dr. Manven. Dr. Manven will give the vote of thanks. I hope she's still on. The Vice President of the societies.
Sir, she is on.
Okay,
She
please,
needs to be unmuted.
can you unmute her, please? Can you unmute Dr. Manven? She's the Vice President.
Yes, ma'am. Please go ahead. We've sent you the notification.
Okay. All right. Thank you.
Thank you,
So,
ma.
good evening, everyone. So I'll just give a short vote of thanks because time has been far gone. So on behalf of the Nigerian Hypertension Society, I would like to extend our heartfelt gratitude to everyone who contributed to the success of this webinar. We are deeply grateful to our esteemed speaker, Dr. Jamila Garba, Dr. Hayatu Umar, Dr. Loretta Michelia, and Professor Oluseyi Adejumo. Your presentations and expertise not only enriched our understanding, but they also sparked meaningful discussions which we all enjoyed. It challenged our perspectives and inspired new ideas in us. Your dedication to sharing knowledge and advancing hypertension care is truly commendable, and we are deeply appreciative of your contributions. We are very grateful indeed once again. To the chairpersons, Professor Hadiza Seidu and Dr. Olaolu Oni, we give you special thanks. Your moderation and guidance ensured that we had a smooth and very productive session, which kept everybody enthralled. Thank you for your time. To our sponsors, MDOC, we extend our sincerest gratitude to your invaluable support in making this webinar a huge success. You played a very pivotal role in ensuring the smooth operation of these events with all the meetings that we had before this session to make sure that it's a smooth session. We are truly appreciative of your partnership, your commitment to advancing the knowledge of hypertension and promoting excellence in hypertension is very commendable, and we are honored to have you as part of our community. Thank you for your trust in us and for your continued support. To the ESCO members here, thank you for your tireless efforts in organizing this. Our indefatigable secretary, Dr. Fassan, the president, we're all very thankful to you. And then to our wonderful audience, this thing would have not been possible without you. To our valued members of the Nigerian Hypertension Society, we all extend our heartfelt gratitude to each and every one of you who joined this webinar. I can see that there's still a number of us still available. 71 is a huge number. The speakers kept us enthralled from beginning since 2 o'clock till now. Your participation and engagement was very instrumental in making this event a success. So we thank you for your time. We thank you for your interest and your enthusiasm. So we hope you found the discussion very informative and valuable. So we look forward to welcoming you to future events. Thank you, everyone. Thank you, Adaora, and thank you, Roderick. They're okay, they're all part of the MDOC. So we thank you very much. So we wish everybody a wonderful day, remaining part of the day. Thank you very much. Bye.
Thank you so much, Ma. Truly, truly appreciate it. God, it was such a wonderful session. I know it went longer than our usual sessions, but it was so educative. We did have 4 speakers, so it's expected. Well done to the team. MDOC is committed to pushing the work forward in both creating awareness and providing self-care support for individuals with chronic health needs such as hypertension. Thank you all for joining. We truly appreciate you for staying this long. Do enjoy the rest of your day, and we wish everyone a pleasant weekend. Thank you. Thank you to all those who joined via YouTube. We will definitely be in touch with you all. Have a wonderful evening.
Thank you so much,
Thank you all. We wish you a fantastic World Hypertension Day on Saturday.
Thank you so much. Bye-bye.
Adora, thank you.
Sunday
MDoc,
or Saturday?
thank
Oh,
you.
17th. Yes, it's on Saturday.
Yes, Saturday, yes.
Saturday.
Thank you so much.
And bye-bye.
Dr. Onita, thank you. Professor Seidu, we appreciate.
Yeah. Thank you so much.
Professor
Bye-bye.
Adejumo, thank you for the fantastic lecture.
Thank you, sir.
I will bump in on you in that Ondo town. One of you know I'm from Ondo town.
Wow, that's great, sir. Thank you, sir.
So thanks to everybody. Dr. Garba, we appreciate. Dr. Shelia, she's still there. Fantastic job. Thank you so much. So have a great evening, everybody.
Thank you.